Let's begin with the next and one of the most important chapters that you have in systemic pathology, and that is kidney. Now, you know this is genuinely a very image friendly and a flooded with images kind of a chapter. So let's get going. And the first thing that you have to know is what is the filtration membrane, or what exactly is the glomerulus made up of? Where is the urine filtered? So let's begin. You see an electron microscopic image in front of you. You can see these red color things are capillaries, right? So what these capillaries are going to have? They are all going to have the endothelium. So the first thing that you have over here is the capillary endothelial cells. After that, the next thing that you see is a straight line going through and through, and that is everything will be present on a basement membrane. So the next thing that you see is a glomerular basement membrane. And who are the feet who are sitting on top of it? So that is this layer of the Bowman's capsule, and which is the visceral epithelial cells. Visceral epithelial cells mainly mean the podocytes. So if you look very carefully, this is the area where the urine is filtered. If you can see, this is the blood, this is the Bowman's capsule. So now try to correlate. If this was the blood vessel, this is the capillary endothelium. If this is the Bowman's capsule, these are the podocytes, right? And what is sandwiched between them? The glomerular basement membrane. So all three of them together make up the filtration membrane. This is a question that came in the NEET PG 2023, where you had to identify a normal structure of a kidney or a glomerulus, and you can very well see something looking like this round ball laddu kind of a thing. That is how students learn it. This goal thing is glomerulus. Okay, goal thing is glomerulus, and if you look carefully, it has the red blood cells inside it, so it must be all the capillaries. These are all the capillary tufts. So this is a glomerulus, and what you see around it, all these structures, they become the PCT and the DCT. So tubules are going to be around it, and this is going to be the glomerulus. Okay, now let's move on to the different diseases that can happen. This is again a previous year NEET and FMG question, and that is to do with putty kidney. Putty kidney, first and foremost, is seen in a case of tuberculosis of the kidney, and the patient is going to always, there is going to be a report of sterile pyuria that is mentioned. Pyuria means there are pus cells in the urine that are seen, but sterile basically means that there are no bacteria that are noted, right? No E. coli or any bacteria, but pus cell hai. Why is there no bacteria? Because actually it is to do with TB. And this is how it looks radiologically, this calcium and necrosis wala mass. And if I'm saying TB, guys, which necrosis am I talking about? The cheesy necrosis. I'm talking about the caseous necrosis, of course. The next kidney, two things that you have is kidney is looking ... like leather grain, and kidney is looking very deadly with red spots. That is flea bitten. So leather grain kidney is going to be seen in a case of benign hypertension, right? Whereas flea bitten kidney is seen in opposite, that is a case of malignant hypertension. So do you think flea bitten kidney mein, what is that flea bitten? Before I tell you the causes, these red color spots that you're seeing is nothing but pinpoint hemorrhages. So this is not seen just in malignant hypertension. We know a very famous mnemonic. Malignant hypertension is just one of them. The mnemonic is we hate PSM, right? So what is V? V stands for Wegener's granulomatosis. Then H, everything will have two things. H stands for HUS as well as HSP, hinox-schondlin purpura. We hate P, P for PSGN and polyarthritis nodosa. Then PSM, S for subacute bacterial endocarditis and SLE, and finally M for malignant hypertension. So repeating, Wegener's granulomatosis, HUS and HSP, PSGN and PAN, SLE and SABI, and malignant hypertension. These can definitely come across as pictures to you in the exam. Leather grain for benign hypertension, flea bitten for malignant hypertension. Next one I've already shown you way back in the general pathology images also, when the kidney becomes waxy, or for that matter when anything becomes waxy, you are obviously thinking of amyloid. Guys, can you tell me, I know Congo red to sabko pata hai, but that is a microscopic stain. Can you tell me a gross stain for amyloid, which I've taught you in your main videos and RR? Lugol's iodine is the gross stain. You will put Lugol's iodine on top of this kidney, and what color will you get after that? You're going to get a mahogany brown color. You will get a mahogany brown color. I hope all these kidney things are done, because abhi I'm left with a few more spotters. The next spotter that you have is the classical spotter of chronic pyelonephritis. Firstly, it's a chronic, and itis means it's a chronic inflammation. Chronic inflammation means which cells am I going to see? I'm going to see a lot of those blue color dot that you're seeing all around. All those blue color dots are lymphocytes. So chronic I've understood, itis I've understood, but what is this pyelo? Pyelo means tubules. So is it a glomerulus problem or a tubular problem? This is a tubular problem. That is why you will notice that the glomerulus is looking badhiya. This goal glomerulus is looking good because problem is here in the tubules. The tubules are showing me that pink material, and what is that known as? That is known as thyroidization of the tubule. So that means if, for example, this is the tubule, it's showing me like a thyroid. It's not actually any thyroid gland, it's looking like the thyroid gland. So thyroidization of the tubules is seen. So it's not a glomerulus problem. Glomerulus is badhiya. So the question that you get in the paper is, which is the only glomerular change that you'll see? So you'll say, ma'am, abhi you said glomerulus is badhiya. I'm still saying glomerulus is good. Glomerulus doesn't have any problem. Around the glomerulus, you might find fibrosis. So periglomerular fibrosis can be seen in chronic pyelonephritis, and this is the only glomerular change that is noted in this condition. So if you ask me what is the cause, देखो infection है तो कोई bacteria होगा. The cause is going to be E. coli, mainly some kind of bacterial infection. Remember this thyroidization of tubules, it's their all-time favorite. Coming to the next, now if the kidney starts looking like this, you know what this disease is. Lots of cysts, PKD, polycystic kidney disease of two types. Autosomal dominant, autosomal recessive. I've taught you the entire theory in the main videos and the RR. I'm doing a quick overview of the images. Please note, if the outer surface also shows the cysts and the inner surface also shows the cysts, that you can see cysts on the outer surface also and inner surface also, that is going to be autosomal dominant, because we had learned dominant matlab dono dono. Dono dono means outer surface also shows you cysts and inner surface also shows you cysts. Whereas where I'm talking about autosomal recessive, recessive means hiding somewhere. The cysts are only hiding inside, which means that the outer part of the kidney is going to look completely normal. The outer part of the kidney shall look completely normal. Only the inner part of the kidney is going to show you these round cysts. Everyone's okay with these two polycystic kidney diseases? Now I'm going to take you into a little bit of urinary bladder also. Again, a previous year question. You can see the urinary bladder, urethra coming out of it. What has happened? This is a condition known as malakoplakia. Firstly, how do you identify this on the gross? All of you can visualize the urinary bladder is showing you yellow plaques. There are yellow mucosal plaques that are seen, and the clinician is going to get worried because clinician will say, Arey, I'm seeing these yellow plaques in the urinary bladder. Is this a case of cancer? Clinician will think it is mimicking cancer. So he will take a biopsy. He will take a biopsy and he will send it to the pathologist. And you know what the pathologist will see? Pathologist will see a blue color ka calcium. Pathologist will say, Arey, this is not any cancer. This is just calcium, because this is showing you the very famous two very important fancy names. Calcium jo hai na, ye blue calcium, that is known as Michaelis-Guttman body. So they always ask you a question. Malakoplakia shows you M for M, Michaelis-Guttman bodies. Malakoplakia shows you Michaelis-Guttman. What is Michaelis? Michaelis में CAK word आता है. तो Michaelis is M for malakoplakia, Kelly's for calcium. ठीक है, Michaelis-Guttman body is made up of calcium. But where is the calcium present? The calcium is present inside some cell. There will always be some big cell which has eaten the calcium, and that cell is known as the von Hansmann cell. So simple things, there are some fancy words. Malakoplakia is a condition that mimics cancer. It shows you yellow plaques in the urinary bladder. But when you do a biopsy, M for M, Michaelis-Guttman bodies दिखेगा. Michaelis tells me malakoplakia, Kelly's tells me calcium से बना है. Who is going to eat up that calcium? That entire cell is known as von Hansmann cell. And what is the condition? It is a phagocytosis defect. This is a phagocytosis defect. So these set of images are done for us. The next set of images is everyone's favorite, and those are going to be crystals. You have so many crystals in front of you. So we are now going to start off with crystals one by one. So let me show you the first set. As you see over here, I've given you the hint. You have to identify the crystal. Where are you seeing them? You are seeing all these crystals on a urine microscopic examination. So let's get going. Let's start with this one, the one that looks hexagonal. So the hexagonal looks like 6, है ना? Hexagonal means 6. So this is referred to as the cystine. Cystine matlab 16. That is how you're going to learn it. 6 wala sides wala crystal is cystine. Then I'll show you, look at this, very thin needles over here and very thin needles over here. So there are thin needles. When I say there are thin needles here and thin needles here, one of them is referred to as tyrosine and one of them is bilirubin. So आप कैसे differentiate करोगे? Of course, which of them is going to be brown and pigmented? Bilirubin is going to be pigmented. So tyrosine, remember tyrosine is also very thin. Bilirubin is also very thin, but bilirubin is pigmented. Coming to the next one, we have something which is looking like this apple thorn. You have thorns coming out. So A for A, apple thorn crystal is seen where? It is ammonium biurate crystal. Remember, apple thorn crystal is A for A, ammonium biurate. And what is the history that you will get? You will get some kind of a laxative abuse that will be given when you start seeing these crystals. Very important MCQ. Laxative abuse is there. Now coming to the next one, when you see this look somewhere, it always reminds me of some parasitology egg, but parasitology egg will go in diarrhea samples. Na ye urine sample hai tree bark jaisa, lamellated. Lamellated as a round lamellation, so L for L. Please remember, lamellated is leucine. L for L, as I said, lamellated is leucine. Let's move on to next one. Now comes in revealing the three main calciums to you. These are three calciums. So the calcium crystal, which looks round like the wheels of a car. Wheels of a car means calcium carbonate. That is why it's going to look round like the car wheels. Okay? Then we have one of them is going to be dumbbell shaped, one of them is going to be envelope shaped like this. So what are these two? One is calcium oxalate monohydrate and calcium oxalate dihydrate. Remember your mnemonic, mona is dumb. Mona is going to be dumb. So monohydrate wala is dumbbell shaped and dihydrate one is going to be envelope shaped. Sorted with calcium, carbonate is car wheel ki tarah round, mona is going to be dumb and dihydrate is going to be envelope shaped. Moving on to the next set of three things, we have something which is looking like a coffin lid, as if there is a lid like this that is coming up. Coffin lid is something which is triple phosphate. Very, very important. I hope you remember in surgery, when this triple phosphate, it is associated with which bacterial infection? It is associated with Proteus. And when this triple phosphate becomes more and more predominant, which kind of stone does it form? It forms the Staghorn calculus, right? It forms the Staghorn calculus. Coming to the next one is my favorite because sometimes it is looking like a triangle, sometimes like rhomboid, sometimes some weird shape, universal shape. Any kind of shape can be seen, and that is going to be uric acid. So any kind of universal shape, uric acid. Finally, we come to the cholesterol. Cholesterol is going to be always broken and means broken chips. And how I have learned it is that cholesterol is having a lot of, who has cholesterol? Chips. The chips that we eat from the market, they have a lot of cholesterol. So of course, the cholesterol is going to be broken chips. Chips se yaad aayega cholesterol. Okay? So now when I get back, this is your final list and all your crystals are sorted for all of you. So let's repeat. Thin needles, tyrosine, broken chips, cholesterol, dumbbell, calcium oxalate monohydrate, mona is dumb, apple thorn, ammonium biurate, thin pigmented needles, bilirubin, universal shape, uric acid, lamellated, leucine. Again, this is a repeat for you guys. So when you're talking about the apple thorn, it is ammonium biurate, and ye dekho round like the car wheels, that is going to be calcium carbonate. Now what is the next thing that I'm going to reveal to all of you? Now comes the story of all the castes. Now when I'm talking about the caste, the first one that you have is again, we moved on from the crystals, we are going on to the caste. We are still in urine microscopic examination. Please note that the hyaline caste is something which is seen in totally normal situations. A normal person sample can show it, and it looks cylindrical like this, transparent, bilkul. So they will ask you, what is it made up of? It is made up of Tam Horsfall protein. So how is Tam Horsfall, or who is making Tam Horsfall protein in our body? Loop of Henle. The loop of Henle makes a Tam Horsfall protein. It's a protein that is made. That is why it looks like a cylinder. It can come out in any normal person's urine sample. But on top of this, if something else starts coming out, if I say that RBCs are coming out along with that, you say RBC caste. RBC caste is seen in glomerulonephritis. If on top of that cylinder some WBC start coming out, I will say WBC caste, that is seen in pyelonephritis. So RBC caste in glomerulonephritis, WBC caste in pyelonephritis. And if something was coming out, but now you don't know ki kya tha. Was RBC coming out? Was WBC coming out? Because everything is looking just ... This means the caste has basically degenerated. So there are some things to problematic, but what is problematic I don't know, because all the cells have degenerated, and that is known as a granular caste. Kya karoge? You'll ask for a fresh sample of urine from the patient. That's about it. Moving on to the next, the one that looks very, very dirty, and that is going to be the muddy brown caste. Please note, in the muddy brown caste, everything is looking so bad and brown because everything has died. This is associated with acute tubular necrosis. You remember what is the history I gave you in your main videos? There will be some kind of ethylene glycol poisoning, so some kind of mercury poisoning. So koi na koi poisoning hoga which has damaged the kidney. And how will they give a history of ethylene glycol poisoning? that a person has consumed an entire bottle of antifreeze or has been exposed to antifreeze which you use in refrigerators and the car carbonators. So person getting exposed to antifreeze or ethylene glycol can have acute tubular necrosis and the urine will show a dead cells, muddy brown cast. Coming to the broadest cast, that is the broad or waxy cast, that is the cast of chronic renal failure. Right? So all your crystals and casts are done, and be rest assured that one question is definitely coming out of it. Moving on to the nephritic and the nephrotic syndromes. The first set that we have in front of us is a patient who has this cola color urine in front of you. You can see what the gross is showing you, the famous flea bitten red color dots, the famous flea bitten kidney. The two most important microscopies in front of you. The first one is the starry sky immunofluorescence. What do we mean by starry sky? Shine and dull. Starry sky, na twinkling stars. Some areas will be shining a lot. Like the stars, you will see some areas are shining a lot. That is starry sky immunofluorescence. And electron microscopy shows you subepithelial humps. Means if I zoom into this picture, I will see ye wo podocytes tha, epithelium, podocytes. Suddenly one podocyte is big like a mountain because something is sitting under it. So that is referred to as a subepithelial hump. Cola color urine with flea bitten kidney with starry sky appearance and subepithelial hump is the diagnosis of post-streptococcal glomerulonephritis. Please remember the blood test shows a very important finding known as transient hypocomplementemia. There's a transient decrease in the complement levels, transient hypocomplementemia. Moving on, P for PSG and P for pediatric. This is the most common nephritic syndrome that you see in pediatric population. So nephritic in pediatric is PSGN. Then what is the nephritic that you see in adults? That is Berger's. Berger's disease ka dusra naam. How will I learn adults? Because Berger's disease is associated with IgA. It is known as IgA nephropathy. And of course, we are gonna see IgA deposition. So guys, A will remind you that this is the most common nephritic that you see in A for adults, right? So P for PSG and pediatric, A for IgA adults. Simple. Now IgA gets deposited where? It's going to get, see, can you see the center areas are becoming very pink over here, and the center areas are showing the deposits, right? It's not everywhere because Berger's mein beach mein deposit hota hai. This beach wala area is mesangium. So Berger's, firstly you will know IgA nephropathy, so IgA gets deposited, and Berger's is in between beach mein, so there is deposition in the mesangium. Moving on to the next one. RPGN, rapidly progressive glomerulonephritis. Patient will rapidly progress and deteriorate, and pathologist will show you crescentic glomerulonephritis. So what is a crescent? I can see one half moon kind of a structure being formed over here. This half moon kind of a structure is crescent. Matlab if this is the glomerulus, there is a flap on top of it. So mnemonic is flap, crescent is like a flap. So what all does it contain? It contains F for fibrin, L for leukocytes, and P for, please listen very carefully, it contains parietal epithelial cells, and it can also contain a little bit of visceral epithelial cells. So flap I've kept as a mnemonic so that you know ki haan, predominantly what you have is P for parietal only, but little bit of visceral cells can also be there in a crescent. The same thing you want to look under the microscope, electron microscope, you will say there is some wrinkled and broken kind of a line. There was a line, but that is broken and wrinkled. So what is that? Remember, RPGN shows you R for rupture and R for wrinkling of the basement membrane. RPGN shows you rupture and wrinkling of the basement membrane. That is a favorite Oscar-winning movie also. That is RRR. So remember, RPGN is the rupture and the wrinkling of the basement membrane. Now, how many types of RPGN do we have? We have 3 types of RPGN, isn't it? RPGN type 1. So RPGN type 1, which we also know as the Goodpasture syndrome. And then we have RPGN type 2. But I have only shown you pictures of 1 and 2. Why? Because RPGN type 3 bhi hota hai, but that shows you no immunofluorescence. There is no deposit in it. Immunofluorescence only of 1 and 2 is important. So 1 में line की तरह, like 1 you write na, way you write 1 is like a line. So you're gonna see a green color which is like a line you will see. You will notice that green color is going like a simple, same color, no shining, dull, shining, koi starry sky type nahi. Same green color here, same green color intensity everywhere over here, theek hai? That is RPGN type 1, like a one single line linear pattern. Whereas RPGN type 2, you will see two colors, shining and dull, shining and dull. This area is very, very bright. Then this this area is very bright, then this area is very bright. So starry sky. So simple. 1 में linear, 2 में two colors, that is starry sky appearance. This is your about RPGN. The last nephritic that you need to know a picture of is the Alport syndrome. Firstly, Al for alpha, P for penta. Which chain is going to be defective? Alpha 5 chain of type 4 collagen is going to be defective when we talk about Alport syndrome. And guys, do you remember the famous triad of Alport syndrome? How is the patient going to present to you? So first and foremost, you've seen the kidney involvement, but what are the things? Eyes bhi, do eyes are also affected, do ears are also affected. In the ears, there is sensory neural hearing loss, and in the eyes, there is going to be anterior lenticonus. And in the kidney, as I'm showing you right now, we will see the very famous basket weave appearance. So I've got you this. Please note and look at this picture. Over here, the basement membrane is looking so nice, like a nice line, right? But over here, if you notice, the basement membrane as if someone has torn it into two parts, as if someone has pulled it across and torn it into two parts. So that is like basket weave. Remember, Alport is alpha 5, alpha 5 chain affected with basket weave appearance, eyes में anterior lenticonus and sensory neural hearing loss. All your nephritic syndromes are done. We can move on to the nephrotic syndromes. Which is the most common nephrotic in child? So nephrotic in child matlab chota sa child, chota sa disease, minimal change, minimal age. Minimal change disease has no diagnostic modality, no light microscope, no immunofluorescence. The gold standard is only and only electron microscopy, and that will show you suddenly. Normally you were seeing the very famous feet, and suddenly you don't see the feet. So that is known as effacement of foot processes is a very important thing that you see in minimal. So please remember, minimal change, minimal age, minimal feet. Chota bacha, chota feet, minimal change disease. Okay? Now moving on to this was children. Na? So if you ask me which is the most common nephrotic that you see in adults, adults वाला nephrotic क्या है? FSGS, focal segmental glomerulosclerosis. What is this picture showing you? It's showing you sclerosis. What do you understand by focal and what do we understand by segmental? Focal means few glomeruli are affected. All of them are not going to be affected. And segmental means that only a part of the glomerulus is affected. See, if you see this glomerulus, has it become entirely sclerosed? No, only the pink. Sclerosis matlab pink, only in one part of the glomerulus. Over here also one part of the glomerulus, not the entire glomerulus. So remember, focal means few and segmental means part. That is focal segmental glomerulosclerosis. Why does this happen? There is going to be HRs 321. What is HRs 321? So H for, you will either have an HIV positive person or a hypertensive person or a person who's on heroin drug abuse. H ho gaya, 3H. What are the two R's? Either the person is having some kind of reflux in the kidney or the person has suffered from some renal tissue loss, some surgery or some cancer. And what is the S that you finally have? The S stands for the famous sickle cell anemia. So like I said, hypertension, HIV and heroin, reflux and renal tissue loss, and sickle cell anemia. That makes it HRs for FSGS. This occurs in adults. Now, nephrotic in elderly. Let's move on to the nephrotic in elderly. Please note that if they ask you two questions, either they've asked you nephrotic, which is a very old person, or they've asked you something to do with cancers. Answer is membranous glomerulonephropathy, MGN. So how I have learnt it is कि देखो, membranous word आया, so the basement membrane is gonna become very thick. Of course, I can see some very thick pink color line is going everywhere. A very thick pink color line is going everywhere. So membranous word I have understood. Then I realized this occurs at the peak of the age, and peak of age पर ही cancers होते हैं. So it occurs at the peak of the age. It shows you peak of the pattern. Peak of the pattern matlab it shows you the famous spike and dome pattern. What is spike and dome? Spike, dome like that. So peak of age पर होगा, peak of pattern दिखेगा. This is the spike and dome pattern. Can you all see these black color spikes that have come out? Like boys make that spiky hairstyle na? Same black color wala spikes have come out. I've got you a higher par, you can see. So this actually, this black color spike, black क्यों है? Because I have used the GMS stain. The GMS is a silver stain, so the basement membrane is gonna come out to be black in that case, right? The Gomori methylamine silver stain, so that is why that peak of age, peak of pattern. But where is the deposit seen, guys? It is a subepithelial deposit. Subepithelial means below the podocyte. Podocyte, na? So if I look carefully, yeah, these are the podocytes. I can see those hanging feet, and things are below the feet. Things are below the feet, so subepithelial deposits are seen in MGN. I'm going to add one word to it. I'm going to add a P over here. It will become MPGN. So what does MPGN show you? So please note there are two types of MPGN. There is MPGN type 1 and MPGN type 2. Now there are only two types. Earlier there were three, now there are only two types. MPGN type 1 shows you the tram track pattern. Tram track means you can see that the basement membrane has two lines. It's no longer a single line. The basement membrane has two lines in it. Hai na? So that is the tram track appearance. Or you can say there is a splitting of the basement membrane that is noted. Whereas what is MPGN type 2? It is known as DDD. DDD matlab it is the dense deposit disease. I can see there is a dense line, black color line which is going everywhere. Hai na? So that black color like line over here that you're seeing, that is referred to as the DDD. Okay? Dense deposit disease, MPGN type 2. I hope you remember from your theory. This is the one that carries C3 nephritic factor, is present in the blood of these patients. C3 nephritic factor has been found. Okay, done with this, we go on to two very important conditions in the kidney. You know, SLE can involve the kidney and so can diabetes. So in SLE, how did we learn SLE? Please note, we wrote SLE and we said that firstly, on light microscopy, it shows you loops, LL. On light microscopy, it shows you wire loops. So if we zoom into this picture, we will notice, yeah, the periphery is very, very pink. Only the loops are coming out to be pink as if there is some wire that you folded, right? So light microscopy pe loop lesion dikhega. Then we had studied that SLE mein everyone is invited for the party. Everyone is invited for the party means it shows you the famous full house effect. Full house effect, again, it is seen on immunofluorescence. Full house means IgG, IgA, IgM, complement protein, C3, C1, C2. Full house party is going to happen. Everyone comes and gets deposited. So E for everyone. And finally, we said SLE ko sign nahi karna aata. Sign nahi karna aata. So someone who doesn't know how to sign is going to put a thumbprint. So here what you see on electron microscopy is the famous thumbprint sign. So SLE, light microscopy pe wire loop. Everyone is invited to the party, so full house effect, and sign nahi karna aata, so that is going to be thumbprint. Now they ask you, this wire loop lesion is what deposition? This wire loop lesion is subendothelial deposition. Now many students get confused that which disease is subepithelial, subendothelial. I'm going to give you one very quick answer in a while. But first, now that you've done SLE, why don't you finish off diabetes also? Diabetes mein most common characteristic lesion, come on, which is the most characteristic lesion of diabetes mellitus? KW lesion, Kimelstein-Wilson lesion. They will always give you a history of diabetic nephropathy, matlab HbA1c is going to be very, very high. And then you will see this. How will I identify this picture if I know the other name? The other name of KW lesion is nodular glomerulosclerosis. It is nodular glomerulosclerosis, means I'm going to see nodules. Yeah, I can see those pink color, chota gola things, right? Those nodules. And if I want to confirm those nodules, what is the stain that I put? Kimelstein-Wilson lesion is PAS positive. I hope everyone's understood. So diabetes ka KW lesion, most characteristic nodular glomerulosclerosis. SLE ka three pictures, you know, these two are much expected. And the last image that you have in kidney is finally this, where you say that, ma'am, this is the final flowchart. Can you tell me which deposit occurs where? So remember, mesangium, beach mein kaun sa deposit hota hai? Beach mein, you know, beach mein there's going to be Berger's disease. So this is Berger's disease, and that is also known as IgA nephropathy. Fine. Which is the one which is subepithelial? Where all did you study? Subepithelial you studied in PSGN and you also studied in MGN. Dekho, kya difference hai? One is a nephritic, one is a nephrotic. How I have learnt it is, subepithelial means it is below the feet. Whose feet do you touch? You touch elderly, people who are elder to you, their feet you touch. So elderly age group mein MGN hota hai. And who touches feet? kids touch feet of elderly people. So kids में pediatric में क्या होता है? PSGN. So when pediatric population PSGN is gonna touch the feet of elderly people, that is MGN, you will say subepithelial, below the feet. This is the deposit, one of a child, one of an elderly. What is left in the membrane? In the membrane there is only one thing I told you, na, that dense deposit disease. Did you remember that thick membrane? So MPGN type 2. MPGN type 2. Now whatever is left automatically goes on to subendothelial. This means you will say, ma'am, I'm left with MPGN type 1. I'm also left with that wire loop lesion. That wire loop lesion that we did in SLE, that was also subendothelial for the time being, right? If you want, you can revise. That was also subendothelial. So ho gaya, simple. First you will say who will touch the feet? PSGN and MGN. Then who will go in mesangium, beach mein, Burgers. Who will go in the membrane? Of course, that dense membrane, dense deposit disease, MPGN type 2, and whatever is left goes in subendothelial. So having discussed the nephrotics and the nephritics, quickly let us go ahead with the renal tumors. The first one is a benign tumor in front of you, which is referred to as oncocytoma, and this is very famous for its color. You can all see the beautiful mahogany brown color that has been mentioned over here, along with a scar in the center, central stellate scar. So before I proceed, what are all the things in pathology that have a central stellate scar, which is going to be very, very important? So we have two things in the kidney. One is an oncocytoma and one is also a chromophobe RCC. Then we have two things in the liver, FNF, that is focal nodular hyperplasia and fibrolamellar carcinoma of the liver. We have one thing in the pancreas, which is serous cystadenocarcinoma, and the last thing is in the breast, which is going to be a radial scar. These are the things which have a central stellate scar. Oncocytoma has a mahogany brown color with a central stellate scar. So your question is, why mahogany brown and what is the meaning of the word oncocyte? All of them mean mitochondria. Oncocyte word means mitochondria. The brown color is because of mitochondria. So I realized that over here, all these things that you're seeing, these black color granules and these organelles, all of these are basically the mitochondria that have been mentioned over here. So this was a benign tumor. What about the malignant tumor? I think we all know the most common malignant tumor that we have is the clear cell, and you can very well see all the cells are going to be clear here. All the cells are going to be totally white because they contain a lot of fat. They contain fat. They can be oil red O positive, right? They also contain glycogen, if you remember from your main syllabus. Coming to the next, papillary RCC. This is just a formality because I know any papillary carcinoma anywhere in the body is going to have some OMA bodies. Yes, so that is very important. Coming on to the next one, which is the tumor which has the best prognosis, the best renal cell carcinoma in terms of prognosis is chromophobe RCC, and that tends to show you the plant cells. Now, what are plant cells? Now, if you read it, racenoid nucleus. So, they're going to have a very, very dark nucleus out here. You can see the nucleus is dark and there's a perinuclear halo. So, there's a whitish area around it. So, same dark nucleus with white area, dark nucleus with white area. These are all the plant cells that we have. And what are they positive for? Plants are positive for Hales colloidal iron. So this blue color thing that is mentioned over here is Hales colloidal iron, and that is what is chromophobe RCC. The last renal tumor that we have is the childhood tumor, that is Wilms tumor, known as nephroblastoma. That kind of tells me, nephro word means it's a kidney tumor, blastoma word tells me that it's going to have something blastema in it. So please remember, this is a triphasic tumor. It has three things. EPB, EMB, what are the three things? Epithelial, mesenchymal, blastemal. So all these round structures that you're seeing, these are all the epithelial component. Then all the spindle shaped structure that you're seeing, those long cells, that is the mesenchymal. And all the blue color cells that you need to see over here, those are the blastemal cells. So all of these guys, all these blue color cells, that's the blastemal component. So clear cut, it has epithelial, mesenchymal, blastemal. Three things make it a triphasic tumor, and you know this is a childhood tumor. So with that, we wrap up our entire section of the renal tumors and the renal pathology images as well. Let's begin with the next chapter images, and that is the central nervous system. I'm starting with the normal cell first. As you can see in front of you, you have an astrocyte which is identified by its star-shaped appearance. And what is this brown color immunohistochemical stain for the same? It is GFAP positive. So all astrocytomas are also GFAP positive. So telling you about the next set, and that is the cell called microglia. I hope you remember microglia are the macrophages of the brain. And I'm going to do some variations. If the macrophage or the microglia becomes long like a rod, that is something you see in neurosyphilis, tertiary or neurosyphilis. If you see that these microglia are going and eating a damaged nerve, neuronophagia, so damaged nerve is being eaten up, that is something you see in cases of polio and rabies. So you can see the damaged nerve over here, and you can see all the microglia surrounding it. If you feel that all these microglia have made a nodule, a cluster, a syncytium, that cluster is known as a microglial nodule. That is what you see in HIV. And finally, if you see that they've made something called globoid structure or globoid bodies, that is something visualized in a disorder, lysosomal storage disorder, which is Krabbe's disease. So globoid is seen in Krabbe's disease. These are all modifications of macrophages or microglia in the brain. Starting off with a disease which is known as the prion disease. These are the two images that you get in the same. Prion disease is also known as TSC, that is transmissible from person to person. Spongiform encephalopathy. And when I say person to person, it is not exactly person, human to human, it is via iatrogenic route. Spongiform means that in the brain there is spongiform changes. Can you all see those white holes? Yes, these are all the spongiform changes that you notice. And one of the prion diseases, which I'm sure everyone knows, is the Kuru's disease. And Kuru's disease shows you this big plaque known as the Kuru's plaque, which is positive for the very famous Congo red and PAS stain. This information is important for INI CET exam. Kuru is positive for Congo red and PAS stain. Discussed all of these prion diseases. Now let's move on to the neurodegenerative diseases, and the first one that we have is everyone's favorite, Alzheimer's disease. These are all the pictures that you have to know. Alzheimer's involves or shows the presence of these neuritic plaques. So neuritic means it has a lot of nerve processes. But what is in the center of this? It is A beta, means there is amyloid. Neuritic plaque is made up of A beta type of amyloid, and I hope you remember it is A beta 40 and A beta 42 amyloid, which is important in Alzheimer's. Then the next set of pictures shows you these cells which are on fire. So these fire cells are referred to as the flame cells or the neurofibrillary tangles, whatever you want to call them, and they are made up of the very famous hyperphosphorylated tau protein. This is a question that you get, and you have got it in the exam earlier. These flame cells are made up of hyperphosphorylated tau protein. Coming to the last one of Alzheimer's, it shows you this body called Hirano body. Hirano body is made up of actin, and we had done a mnemonic, hero ko acting karana, right? Hero has to act. So Hirano body is going to be made up of actin. All these are together going to be included in Alzheimer's disease. One last word, the pink and blue stain everyone identifies, but what is this blackish color stain? This blackish color stain that has been used is referred to as the Bielszowski stain. It is something which you would see being used in the brain. So Bielszowski stain is important for the brain. Let's move on to another neurodegenerative condition, and that is the Parkinson's disease. In Parkinson's disease, now normally, if I show you the normal substantia nigra, you know normal substantia nigra has melanin, so brown color. But in Parkinson's disease, as you can see, that the substantia nigra has become very pale because the melanin production has gone down. That is the pathogenesis of Parkinson's disease, right? And what does it show you microscopically? The Lewy bodies. Guys, what are Lewy bodies made up of? They are made up of alpha-synuclein. And how did you learn this information? We had studied that park and lawn are synonyms. Park and lawn mean the same, na? So park and lawn are synonyms, and that is how you have identified this, right? So Parkinson's also done. Neurodegenerative diseases are over. You can see this Lewy, nice round Lewy body out here, which is very, very famous in the exam. You can zoom it and see it as well. Park and lawn are synonyms. Now let's move on to the CNS tumors. So the first one that you're going to study is the CCC tumor, which means that you're going to have a child who is going to have a cystic lesion in the cerebellum. There's a cystic lesion in the cerebellum, and you have the same shown above. There's a cystic lesion shown in the cerebellum. Microscopically, you are seeing these long fibers called Rosenthal fibers, and that is what is referred to as pilocytic astrocytoma, or you can even call it juvenile pilocytic astrocytoma. So JPA is the other name. I hope you remember this is a very, very good tumor. It's a grade 1 tumor, so the prognosis is good. Now, from a child with good grade 1 tumor. Let's go to adult with a very, very bad tumor. So when I pick up an adult over here and I say that the tumor is grade 4 category and very, very bad, we are talking about glioblastoma. Anyway, anything blastoma in the brain is bad. Bomb blast in the brain is bad. So we had learned that glioblastoma is all about wildlife, nature, animals. First thing that it shows you, there's a butterfly glioma that is noted. You can see the left and right butterfly appearance that you have over here, right? Next, we had studied microscopically, it shows you something like a snake. Means there is a serpentine necrosis. And apart from serpentine necrosis, you will see that there is something going around those serpentine necrosis. Pseudopalisading of the tumor cells. All the tumor cells are around the snake. Pseudopalisading of the tumor cells. So I realized there's a butterfly involved, there is a snake involved. So now when I ask you what is the genetics, you will say 90% of the cases are going to be IDH and 10% are also IDH. But what's the difference? The 90% cases are IDH of the wild type and 10% of the cases only show you IDH. IDH matlab isocitrate dehydrogenase, IDH of the mutant type. So again, wildlife had to be given importance, right? 90% of them are IDH wild type. The last point, you won't get a picture on it, but remember GB mein GB. If they ask you glomeruloid bodies are seen in which condition, you will say glioblastoma shows you glomeruloid bodies. Moving on to the next tumor, which is everyone's favorite, showing you the famous fried egg appearance. Yes, and you can see the same over here. There is a nucleus with a white area. That white area around it everywhere is referred to as the fried egg appearance. And there is a rule of the universe. Wherever there is an egg, there has to be a chicken. Can you all see that there are some weird blood vessels coming? And see one more picture. There are some really weird blood vessels which are doing the rounds over here, right? So remember, fried egg appearance with chicken via blood vessels is indicative of oligodendroglioma. No, we do not write oligodendroglioma like this. I'm going to slash it out because we all had a rule. Whenever we will write oligodendroglioma, we will make lots of eggs in it so that we will always remember that it is the Andawala tumor. It is a tumor which is going to show me lots of eggs and chicken via blood vessels. Most commonly, this also shows you the IDH mutation, but in the exam, they ask you, there is a co-deletion that is seen, co-deletion 1p19q that you see in oligodendroglioma, and that is going to carry a good prognosis for the patient. Coming on to the next 2-3 tumors, which are going to be a beautiful display of all the rosettes important for you. Please note that first you need to understand what is a pseudo rosette versus what is a true rosette. So pseudo rosette is always going to be pseudo, fake person. Fake person will have something hiding in his heart. Something will be hiding in the heart. So if they say perivascular rosette, there's a blood vessel in the center, and then the cells are around it. Matlab something in the center, hiding in the center, this is pseudo rosette. This is something that you see in ependymoma. Coming to the next, Homer writes pseudo rosette. Again, it has the word pseudo. Something must be hiding in the center. I can see pink material that is hiding in the center. Where do you see Homer writes pseudo rosette? Remember our very famous mnemonic we always study that either men are pseudo, men are fake, or men are right, whatever you want to learn it. So which brain tumor? Medulloblastoma. One more tumor that is neuroblastoma, and there's a bone tumor that is Ewing sarcoma. So remember these please, that is medulloblastoma, Ewing sarcoma, neuroblastoma. Men are right, men are fake, Homer right, pseudo rosette. Finally, coming to a true rosette. What is the definition of a true rosette? Something which has a clear center. The center is totally clear, totally empty, clear center. That is known as a flexner intestinal rosette. Have a look at the center, it's white. Center is white, and this is something you see in the eye tumor, that is retinoblastoma. This is a beautiful description. Concept being something is in the center, matlab kuch fake hai. Center is clear, perfect. This is clear-hearted, real, true-hearted person. Moving on to the next tumor, the tumor which is known as meningioma, and you will always get something to do with the female history because this is the tumor which is dependent on a hormone called progesterone receptor, the only brain tumor which is progesterone receptor positive. Plus, you can see the beautiful meninges. The tumor is arising from the meninges, and I hope you all remember in radiology we see the very famous dural tail sign. Now, what do you see microscopically? In pathology, I say everything is going goal. Everything is going goal. The cells are also going round and round. See, the cells are arranged in a round manner like this. This is known as whirling of the tumor cells. Further, if you look, calcium is also arranged round and round. So, everything going round and round. Whirling of the tumor cells is seen, and the famous round and round calcium psammoma bodies are seen. These are features of meningioma. Coming to two, three tumors which are only important for INI-CET. There is a grade 1 tumor in the brain known as DNET. And how do we identify DNET? You will see the background is looking like water. There are lots and lots of mucin present, and some cells are floating inside it. Some cells are found floating inside it. Those are referred to as floating neurons. So there are floating neurons in pools of mucin seen. That is DNET, grade 1 good tumor. Similarly, another tumor that can come to the brain, or especially if you have an HIV positive person, you must have heard that HIV positive people in the brain tend to have CNS lymphomas, guys, which is the most common CNS lymphoma in HIV positive situation? DLBCL. Remember? How do you identify lymphoma? These two words in the brain you will have to look out for. So the lymphoma cells are angiocentric. They'll say, oh, there is a blood vessel, I will go and sit there. So यहाँ पे blood vessel है, tumor cells are sitting here. Blood vessel, tumor cell. Wherever they are finding blood vessel, they will go and sit there. So angiocentric arrangement they will have. And further, I saw that when I wanted to find out reticulin fibers, I saw that around every cell there is a reticulin fiber. See, this must have been a cell, fibers are around it. This must have been a cell, black. So if I draw the cells, you are seeing how the fibers are encircling the cells. Hai na? That is known as the hooping pattern. So whenever they use words like angiocentric and hooping in the brain, they're talking about a lymphoma. Most likely it will be an HIV positive situation with DLBCL. Now moving a little away from brain, something that can happen in any part of the nervous system is the most famous schwannoma. And we all know that this is very frequently associated with neurofibromatosis 22. It is associated with neurofibromatosis 2, chromosome 22. How do I identify it? I noticed that this part of schwannoma has a lot of cells. A lot of cells means it is Antony A area. Antony A, as I can see, a lot of cells. A for a lot of cells. The other one is looking very, very blank. That is Antony B area, totally blank. Can I say Antony A area is hypercellular and Antony B area, that is blank, is hypocellular? Yaad rahega, A for a lot of cells, B for blank. Also, what you see in this tumor is the famous Verrucke body. So your question is, how does a Verrucke body look like? Have a look at this, guys. A Verrucke body, another thing that is going to show you 2. So please note, a Verrucke body is going to show you 2 rows of nuclei. 1 row of nuclei over here, 1 row of nuclei over here. So 2 rows of palisading nuclei, and where will the cytoplasm go? All the cytoplasm will be in the center like this. So this entire thing mentioned over here becomes a Verrucke body, repeating 2 rows of palisading nuclei with cytoplasm. So they ask you, which is the brain tumor or neural tumor that shows you palisading nuclei? It is schwannoma, associated with NF2, chromosome 22. Another tumor which can occur in the brain but not inside the brain, but something which is very important. What is the site of this, guys? If I'm saying craniopharyngioma, you know this is going to be suprasellar in location. This is suprasellar in location, and we know that this arises from the Rathke's pouch. Please note that this tumor is going to be usually seen in children, and suprasellar matlab, what is it going to compress? It is going to go and compress the optic chiasm. So there are going to be vision disturbances that the child is going to come to you with. How will you look at it under the microscope? Periphery pe you will notice the cells are palisading. All the cells are parallel to each other. So periphery shows you peripheral palisading. Then you will see that there are some loose cells, alag. They are all away from each other. So these loose cells are known as stellate reticulum. And finally, you will see some pink keratin, that is known as wet keratin. You will say, ma'am, pink hai. You could have called it keratin. Why are you calling it wet keratin? Because this is gonna give the appearance of machine oil. So they say that which is the brain tumor which is going to have a machine oil fluid coming from within it, brown color ka machine oil fluid, that is going to be craniopharyngioma. So remember, craniopharyngioma is arising from the Rathke's pouch, suprasellar, to matlab it will compress the optic chiasm and result in vision problems in a child. Peripheral palisading is seen, stellate reticulum is seen, wet pink keratin is seen, and with the eyes, how will you see that? Brown color ka machine oil fluid. And with that, we have wrapped up all the CNS tumors and in general all the CNS pathology images. So let's begin with the next set of images, and that belongs to the female genital tract, male genital tract and breast pathology. Starting with the FGT, we first have the cervix, and you know the cervical pap smear, that is very, very important. So this is how a conventional pap smear is done. What is this, which they ask you very often in gynecology? That is an iron spatula that you use for doing a pap smear, and you put all the material on the slide over here. So this is exactly how your slide looks like. It looks like a really dirty painted place because the iron spatula has painted the entire slide. This is how you'll identify it. But now what is preferred over a conventional smear? We now prefer a technique called liquid-based cytology. What do you use? A brush and a container. So you use a brush and a container, that is how, which has a liquid. So that is how you're going to identify liquid-based cytology, and the slide will always look round like this. So first you need to know that liquid-based cytology is of two types, that is sure path LBC and thin prep LBC. Sure path LBC, S for S, is going to have a small circle on the slide, roughly going to be 13 mm. Whereas sure path is going to have a bigger circle of 20 mm. So that is the difference between sure path and thin prep. So as I said, sure path S, small circle S, 13 mm, whereas thin prep is going to be bigger circle, 20 mm. The techniques are done. Let's identify the cells. Let's look at these slides under the microscope. So the first cell that you see is going to be the squamous epithelial cells, means ectocervix. Ectocervix, then endocervix. Ectocervix mein you have superficial cells, intermediate cells, parabasal cells. How will I identify? जो pink color wala cell hoga, that is superficial. So remember, superficial cells are going to be pink, polygonal, pycnotic. What did I say? They are pink, polygonal and pycnotic. So I can see the pink color, yes. I can see the polygonal shape, correct. And pycnotic, look at the nucleus, it's like a dot. So pink, polygonal, pycnotic is superficial. What is intermediate? Of course, it will be blue. Ek pink hai, the other one's going to be blue. So this cell that you have over here, all these blue color cells then become intermediate. And finally, what is at the base? Parabasal. They are always going to be present in the form of a cluster. So parabasal cells are clusters. So remember SIP, superficial, intermediate, parabasal. The superficial one is pink, intermediate is blue, parabasal is going to be like a cluster. This was your ectocervix. How is your endocervix going to look like? I hope you remember endocervix is columnar epithelium. So how is it looking like? It's looking like a picket fence or butterfly on fence appearance, mainly because it is columnar epithelium. But that is, if I show you the pencil like this, you will say it is columnar epithelium. If I say look at the pencil from the top, look at it from the top, you will say it's a dot, hai na? Like this it's columnar, but like this it's a dot. So when I look at the top view, I see that these cells, the head of these cells I'm seeing, so the top wala view I'm seeing, that is known as the honeycomb pattern. So these two words are for the same thing. Endocervical cells can look butterfly on fence also, they can look honeycomb also. This was about cervix, but can sometimes endometrial cells also be seen? Yes. Endometrial cells are identified by the fact that they look like 3D ball clusters. 3D ball clusters are endometrial cells, and sometimes, so when will you see endometrial cells? You will say, ma'am, when the female is menstruating, that is the time when her endometrial cells are shedding off, means day 1 to day 5 when she's bleeding. But even after she stops bleeding, after day 5 when she stops bleeding, even after that for the next few days, 6th to 10th day, some amount of endometrial cells shed off, and that is known as exodus. What is an exodus? You will see a central dark area and a periphery light area. Maybe she won't see any bleeding. With her eyes, she won't be able to see bleeding, but these cells are being shed off, and that is exodus. So remember, endometrial cells or exodus, they are the same thing. They look like round balls, but endometrial cells are shed off usually during menstruation. Exodus is the form that is shed off between day 6 to day 10. Now let's come to infections that you see in a pap smear. The first one, going a little bit into microbiology, I think everyone knows Trichomonas, which shows you the very famous strawberry cervix. And how did we always draw the strawberry? That the strawberry is obviously red, of course. But what is the top of the strawberry? That is going to be green, because how do these patients present? They always come to you with a greenish discharge. There is a greenish discharge per vaginum that she will say. Apart from that, how do you identify the organism? The organism is going to be a pear-shaped organism. Very difficult to pick up. How will I identify these pear-shaped organisms? So these pear shapes are nothing but the meatball. And you know what do they usually come up with? They usually associate with their best friend, that is Leptothrix. So remember, these long spaghetti, those are nothing but Leptothrix, and these tiny meatball, that is going to be Trichomonas. So Trichomonas and Leptothrix make the spaghetti and meatball appearance. Very important, they always tend to occur together. This was the first infection. Coming to the second infection, KKK. If a female comes to you with a curdy white discharge, you start thinking of Candida, and microscopically you see kebabs. I'm ruining that forever. So curdy white, Candida, kebabs, all KKK wala sounds. So shish kebab effect. Why? Because Candida is very famous for having pseudo hyphae. So ये वो stick हो गया on which you keep the kebabs. So this is going to be the pseudo hyphae. And on top of that, all the cells are going to come and get deposited. These are all the cervical cells. These are your pieces of kebab. So you can see a shish kebab being formed over here. Shish kebab. As I said, Candida, curdy white, shish kebab. Moving on to the next infection, bacterial vaginosis, which you know is caused by Gardnerella vaginalis. Very important in microbiology. So they are what? They are cocobacilli. I'll draw them as a dot. Where are they going to be present? They will stick onto the cells. Can you see they are sticking onto the cells over here? These are known as clue cells. They will also go in the background. When they'll all go, see, background ऐसा बिल्कुल white नहीं है. It's a little bit of a hazy background because all these cocobacilli are in the background. So you call it a filmy background. So someone asks you, what is the reason for a filmy background and what is the reason for a clue cell? You will say the reason for both of them is gonna be cocobacilli. Coming to the next infection. With this, you will always get a history of intrauterine contraceptive device, and that is actinomyces. How do you identify? It's looking like a ball of fur, right? So this is known as a lot of names, but they mean the same. Cotton fibers or wool fibers or dust fibers or sun ray, they all indicate that this is going to be a filamentous organism. And you can see the filaments coming out. So you call it cotton, wool, dust or sun ray, it means the same. One scientist name is also given to it, and that is the Gupta bodies. But always remember, there shall be a history of IUCD usage. Moving on to the next infection, which everyone knows. Where do you see a coilocyte with human papilloma virus infection? What is the description of a coilocyte? You've done it so many times. You see a very dark nucleus. A very dark nucleus called the racinoid nucleus, and around it there is a white area. Around it there is a white area known as perinuclear halo. So racinoid nucleus with perinuclear halo is referred to as a coilocyte, and that is what you see with HPV. These were all the infections that you could see on pap smear. But what is the pap smear main reason? I want to pick up cancer. How does cancer look like? Which cancer am I talking about? Squamous cell carcinoma. It shows you tadpole cells. Have a look at this long, lengthy tail wala cell. Also look at this one with the tail. So tadpole with the tail, it's something like a big cell and it will show you a tail like this. This cell is referred to as a tadpole cell, which is indicative of squamous cell carcinoma. Cervix is done. Let's move on to endometrium and then ovary. Under endometrium, the first thing that you have is a disease called endometriosis. What is endometriosis? When what all? Tell me the definition from gynecology. What is the criteria? The criteria says that you are supposed to have three things: endometrial glands with the endometrial stroma, and they should be bleeding also, means hemosiderin. Glands, stroma and hemosiderin, all three things are present where? They are going to be present outside the uterus. They are going to be present outside the uterus. So over here they are present in the ovary, and that is what you call as, see, the bleeding. You can see this brown color old blood. Brown color old blood matlab this is a case of chocolate cyst. So remember, chocolate cyst is nothing but endometriosis that has occurred anywhere outside the uterus. It could be ovary, broad ligament, lungs, intestine, anywhere outside the uterus. Endometrial gland, stroma and hemosiderin, three things have to be present. Keep that in mind, but outside the uterus. I change the definition and I say, what is adenomyosis? You'll say that is also endometrial glands and stroma, but instead of the endometrium, they are not going outside the uterus. They have just shifted a little away into the myometrium. They have gone a little away into the myometrium. So you can see these are the endometrial glands, and what is this? The aspas, there is muscle. So they have just shifted from endometrium, gone a little bit into myometrium. That is adenomyosis, andar hi andar. That is how we had learnt it in our theory. Andar hi andar, from endometrium to myometrium, but in the uterus. What if it exits the uterus? It goes, endometrial glands and stroma go into the ovary. Exit kar gaya, that is going to be endometriosis. I hope there is no confusion between the two. Endometrium done, we can go on to the myometrium. What is the tumor of the myometrium known as? Fibroid or leiomyoma. Yes, you can see multiple leiomyomas that you have over here, and they're usually grey-white in color. But suddenly I say this fibroid or this leiomyoma has become red in color, you will say that is indicative of a red degeneration. Red degeneration is something that usually happens in pregnancy, and the female is going to come to you with pain and fever. So, you know, pregnancy mein female coming to you with abdominal pain, you start thinking of miscarriage, abortions, but that is actually not the case. Her fibroid has undergone a red degeneration, beefy red color you can see, and that is what you see in pregnancy. How do fibroids look under the microscope? Again, I can see something going round and round. This round and round is the whirling pattern. Whirling pattern is seen, and when you look at the cells a little on high power, they will look like cigars. Anything to do with a smooth muscle will always look like a cigar, right? So remember, they are going to show you cigar nuclei. Anything to do with a smooth muscle, leiomyoma is a smooth muscle tumor, right? Anything to do with smooth muscle is going to be a cigar. So cigar is more smooth in comparison to a cigarette or a beedi, right? So cigar is smooth is how we will learn it. Now, done with the different kind of endometrium, myometrium, I'm taking a detour. I'm going a little bit into gestational trophoblastic diseases. Gestational trophoblastic disease means high datidiform mole, and like I say, high datidiform, it feels filled with hydra, water. So I can see these big vesicles, grape-like vesicles, and when I try to look at these under the microscope, these are nothing but these water balloons are actually the villi. These water balloons are hydropic villi. So I hope you read in your theory there are two types of mole that you have. There is a partial mole and then there is a complete mole. I'll ask you a quick question. Which of them is going to be showing you fetal parts? So you will say partial mole is partial fetus, partial mole. So in this you will see the presence of fetal parts, whereas complete mole is completely mole. There is no fetal parts that you're going to see at all. Okay? But yeah, do go through the theory from your GTD part of female genital tract. Now done with this, we move on to the ovarian tumors. The first set of ovarian tumors that I start is SSS, MMM, BBB. What is that? SSS means serous ovarian tumors are gonna be serous, single cysted and ciliated. Serous, firstly, single, you can see uniloculation, you can see just one cyst. And what is the epithelium? The epithelium that you see has a lot of cilia. So single, serous and ciliated. SSS comes together. Also, if you want to add that S, this is the tumor that can show you the Samoma bodies. So SSS all comes together. What is MMM? Firstly, mucinous, you will see all mucin inside it and you can see multiple cysts. It is a multiloculated cyst that you're seeing. And which epithelium will you see? Up common sense, mucinous epithelium I will see. So MMM, mucinous fluid, mucinous epithelium, multiloculated, MMM comes together. Now let's come to BBB, which is the tumor that shows you coffee bean. Look at the nucleus. The nucleus has a line going through it. So please remember, B for Brenner tumor. Coffee bean is seen in Brenner tumor. What else do you see in Brenner tumor? Brenner tumor is very famous for bladder epithelium. Guys, which is the bladder epithelium? Urinary bladder ka kya epithelium hai? Transitional epithelium, right? Transitional epithelium. So I have learned BBB. Brenner tumor mein bladder epithelium hoga and bean appearance hoga. But where else in ovarian tumors can you see the bean appearance? So all of you who are coffee lovers, you know that for coffee you should have coffee grains, granular powder, and you will have to brew your coffee. You will have to brew the grains to get a good coffee. Hai na? So brew the grains for coffee. Brenner and granulosa cell tumor show you coffee bean appearance. Okay? Brew the grains to get a good coffee. Brenner and granulosa. Jisme Brenner is not only bean but is also the bladder epithelium. Moving on to the next, a germ cell tumor in the ovary, which is dysgerminoma. Now you put it up as dysgerminoma in the ovary or in the testes, you can refer to it as a seminoma. It pretty much means the same. They are very famous for having khali cells like fried egg. They can show you these totally empty looking cells like fried egg that you have. And apart from that, can you see this cluster of blue color dot? This is lymphoplasmacytic infiltrate. So clear cells that you see which are fried egg with lymphoplasmacytic infiltration is either dysgerminoma or a seminoma. Look at, now I know this is ovary, but if I show you the testis wala, see, you can see this testicular tumor. Seminoma is known as a cut potato appearance. It's a cut aloo, okay, cut potato appearance. And you see the same thing. You see all khali cells, the fried egg, number one, same thing. And can you see a cluster of all these blue color dot lymphoplasmacytes? So same thing that you see in seminoma, dysgerminoma. So dono ka marker is also going to be the same. Both of them are going to show you LDH and FLAP positivity. So dysgerminoma also shows you LDH and FLAP positivity. Seminoma is also going to show you LDH and FLAP positivity. But what was the question in our theory? Which is the one that is never ever seen in it? AFP is never ever going to be a tumor marker for seminoma, dysgerminoma, because AFP is a tumor marker of alpha fetoprotein, is a tumor marker of the yolk sac tumor. So yolk sac tumor mein what is the body that you see? The very famous Schiller-Duval body or the glomeruloid body. How does it look like? Think of a glomerulus. You will have a blood vessel in the center. And how many rows of tumor cells you will have? You will have one row like this and one row like this. So simple. You will have two rows of tumor cells. So this is a tumor, and in between them you will have a space. Simple. So center mein kya hai? Center mein you have a blood vessel. Sorted? Blood vessel dekh liya. Then you have one row of tumor cells over here, one row of tumor cells on the outside, and in between the two you've got a space. That is known as a glomeruloid body or a Schiller-Duval body of yolk sac tumor with alpha fetoprotein positivity. Which is the ovarian tumor with beta HCG as the tumor marker? Beta HCG is seen as your immunohistochemistry also, choriocarcinoma. So how do you identify choriocarcinoma? It is that ovarian tumor where you just see lots of blood and lots of necrosis. Lots of hemorrhage and necrosis are seen. And microscopically, you see two types of cells, cytotrophoblast and syncytiotrophoblast. Cytotrophoblast and syncytiotrophoblast, if you want to visualize, the one that has one nucleus, cytotrophoblast. The one in which a syncytium is formed, multinucleated, syncytiotrophoblast. Syncytium matlab group. So, if I show you one nucleus matlab cytotrophoblast. But if I show you too many nuclei like this, so too many nuclei together, they are going to be syncytiotrophoblast. Okay, with choriocarcinoma, beta HCG tumor marker, very important. The next one is a visual delight, everyone's favorite, teratoma. Teratoma, we know, we've identified it. Not only will we get to see a lot of hair tuft, we can sometimes see teeth, we can see bones, so many things can be seen. But they ask you that what is this protuberance that you're seeing over here? This is the Rokitansky protuberance. What is hiding inside it? No one knows. It may have a foci of cancer or may not. May or may not have cancer, so you will have to cut through it. The concept is that you will have to cut through a teratoma, cut through the Rokitansky protuberance to find out whether cancer is hiding in it. This is also having a cyst over here. It's a cavity or a cyst. Dekho, it's a cavity or a cyst. So guys, this teratoma that you have over here in this picture is a dermoid cyst. What is the definition of a dermoid cyst? It is a teratoma. It's a mature teratoma only, but additional kya hai? It is going to have a cyst in it. So dermoid cyst is a mature cystic teratoma that you have. Okay, coming on to almost towards the next gross, which is important. Suddenly you have two ovaries enlarged and they are having too much of golden material. Could you have thought of chocolate cyst? Ovary mein bleeding type ka lag raha hai, chocolate. Endometriosis could have been one, na? I also think it is endometriosis. But when I saw the microscopy below, I saw a lot of thyroid. What is thyroid doing? Now I know, acha, ye golden color was not chocolate cyst, this was colloid. What is thyroid doing in the ovary? That is known as a condition all called as monodermal teratoma only. Now you don't have hair, skin, teeth, bone, ye sab nahi hai. You just see one thing, and that is monodermal, just one thing, that is thyroid. And the most important and very interesting point is, this thyroid is functional. There is going to be T3, T4 production that is going to occur. Imagine ovaries will start producing the thyroid hormones. That is known as struma ovary. So very important. Struma ovaries, thyroid gland seen in the ovary. Moving on to the next, everyone remembers this story. It's a sex called stromal tumor called granulosa cell tumor. Remember granny? Granny matlab we had 99-year-old granny. This occurs in very old people who are 99 years old. So this was CD99. And remember that granny had gone a little hormonal and she had done what? She had done something which is inhibited. What was the inhibited thing that she had done? Number one, inhibin is the tumor marker. The inhibited thing is she called her ex and invited him or her for coffee. So she invited her ex for coffee. Calling the ex and inviting for coffee is the inhibited mistake, wrong thing that she did. So calling the ex matlab call exner bodies. Call exner bodies are gonna be round like this with some pink material in the center. So round with pink material in the center is call exner. So she called her ex, and did I just tell you that yes, we will see the presence of, look at these coffee bean nuclei that you're noticing here. So they said that you will see the presence of these coffee bean nuclei. Where else? Brew the coffee grains है ना, brew मतलब brenner, grains मतलब granulosa. तो coffee beans को brew the granules, brenner and granulosa cell tumor show you the coffee bean nucleus. So calling the ex for coffee, bad idea. So tumor marker inhibin, she's 99-year-old granny, old age में होता है, so CD99. Let's move on to the next tumor, which is the thing that shows you these Ranke's crystalloids. Firstly, Ranke's crystalloids are seen in anything to do with Leydig cells. That could be a normal Leydig cell also, that could be a tumorous Leydig cell also. Anything to do with a Leydig cell, normal or Leydig cell tumor is going to show you these Ranke's crystalloids. The last image is when there is some kind of a tumor which is coming to the ovary. What is that tumor coming to the ovary? That is known as the Krukenberg tumor. Please note, Krukenberg tumor is most commonly what is coming. Anything can come to the ovary, of course, but the most common tumor that is coming to the ovary is the stomach cancer. So gastric cancer coming to the ovary is the most important example here. And what do you see in this? You see the famous signet ring cells. What is a signet ring cell? You will see the nucleus is going to be pushed at the periphery. Why has the nucleus been pushed at the periphery? Because you have mucin that has come in. So you will visualize, look at this guys over here, beautiful picture. The nucleus has been pushed to the periphery. Why? Because there is blue color mucin that has come inside. All the other pictures, this is one of my best favorite one. How the nucleus is at the end because of mucin. All of these are signet ring cells that you're seeing, indicative of Krukenberg tumor. So quickly, this is a review of all your ovarian tumors also. And testicular tumors go hand in hand. In the entire male genital tract, all these pictures shall remain the same, with only one additional picture that I want to show all of you when you're talking about the testes or the male genital tract. Please note that if ideally, do you do FNSC of testicular tumors? Do you do FNSC? We won't do FNSC. But can you do FNSC from a lymph node? अगर testicular tumor में lymph node है, so then can you do the FNSC? Yeah, then I can do FNSC. Testicular tumor mein I will not do FNSC, but lymph node mein I will do FNSC. So when I saw like inguinal lymph node tha, I did an FNSC. Cells were seen okay, but my concern over here is look at the background. The background is dark and light like tiger stripes. Tigroid background. Remember, tigroid background on FNSC is gonna be indicative of some kind of a germ cell tumor. Most likely, it is a case of seminoma. Most likely, the germ cell tumor is seminoma. So, they will say there is a male patient who has a testicular mass and a lymph node mass. FNSC karna hai. You say testicular tumor mein to I will never do FNSC. Lymph nodes I can do FNSC, and I started seeing this tigroid background, which gave me a hint that maybe in his testes he is suffering from a germ cell tumor, that is seminoma. Sorted. This is the only extra picture for male genital tract that you had to know. The next one that we are going to go on forward and do is obviously the breast pathology. I know breast tumors is what everyone is waiting for, but before we get to that, let's do some miscellaneous chota mota things, which is fibrocystic disease, which is obviously going to show you fibrosis. It is also going to show you cyst formation. I can see that bluish color cyst. I hope you remember in surgery we refer to it as a blue dome cyst. That is what is important. Surgery it is called as blue dome cyst. And of course, along with that, can you see there are some really pink cells, very pink cells, and they are throwing there as if they are, spitting out some secretions. They are trying to spit out some secretions. So what are these known as? These are known as the apocrine cells with apocrine snouts. So basically apocrine cells तो मतलब वो जो pink cells हैं, and what they're trying to spit out ना, that is known as snout. So apocrine cells with apocrine snouts are seen in fibrocystic. You will pick it up in the exam by looking at this blue dome cyst. This is important for INICT, not really for NEET and FMG, right? Moving on to the next, again I told you, did I teach you a long list some time ago where I told you that there is going to be a central stellate scar? Which part of the breast shows you a central stellate scar? Again important for INICET, is going to be the radial scar. So you will see some fibrosis wala scar. Again over here I see some fibrosis wala scar. So remember, a central stellate scar is something which is indicative of radial scar in the breast. And I gave you kidney, liver, pancreas. We've done that list earlier. Breast wala I just wanted to revise. Now let us start off with the tumors. The first tumor that I'm going to start off with is everyone's favorite fibroadenoma, which the radiologist is going to call to you as a breast mouse. And one more thing the radiologist is going to mention, that is popcorn calcification. I will tell you what a pathologist is going to tell you. So when an FNSC is done, you will realize that we see all these staghorn appearance. All the cells are arranged like the horns of a deer. Staghorn clusters are seen on FNSC of fibroadenoma. But when we remove it surgically, we get two patterns: intracanalicular fibroadenoma, pericanalicular fibroadenoma. Dekho, intra, how do you write intra? Intra is written I, peri is written P. So which of them is Pichkawa? I. I is going to be looking like this. So how are the ducts and glands looking? They are all compressed. All the glands are compressed. I ki tarah, that is intracanalicular fibroadenoma. If they are all open like a P, if they are all open like a P, this means that is pericanalicular fibroadenoma. This is only for pathologists. Clinically, no difference. Intracanalicular equals pericanalicular from patient point of view. Okay? But this is only important from our actual point of view of a pathologist. So remember, I ki tarah, P ki tarah, intracanalicular, pericanalicular. That is fibroadenoma. There's one more tumor in the stroma that all of you know, and that looks like the very famous leaf or the phylum. So the leaf or the phylum one is going to be known as the phyllodes tumor, right? And how many types of phyllodes tumor do we know? We know there is benign, borderline and malignant. How do we differentiate? We differentiate them on the basis of their mitosis. Remember, if there are less than 5 mitosis, it is benign. 5 to 9 mitosis, borderline. 10 per 10 hypa field se zyada. If more than 10 per 10 hypa field, that is malignant. Always remember. They ask you, phyllodes tumor is benign, borderline or malignant. You say sab kuch. Mitosis less than 5, 5 to 9 and more than 10. That is indicative of benign, borderline or malignant phyllodes. Now, fibroadenoma and phyllodes are done. So we can move on to the next set of tumors. Please note, I'm going on to the ductal tumors first. Matlab, we are talking about ductal carcinoma in situ. Guys, whenever I have an in situ tumor, that means the basement membrane is still intact. There are two types of DCIS. Cribriform DCIS. Cribriform, so everyone knows. What is cribriform? Cribriform means channi, sieve. Cribriform means channi or sieve. So you can see these holes of a sieve or a channi inside it. That is a cribriform DCIS. What is comedonecrosis? Comedonecrosis DCIS means comedon. Everyone has had growing age mein, puberty mein, everyone has had acne. Na? Acne is comedon. So when we used to press that acne, some very bad, dirty material used to come out. Similarly, over here inside the duct, if you see, some very dirty looking material is present. Very dirty material like acne. So that is why it is known as comedonecrosis DCIS. Ye channi wala is known as cribriform DCIS. This was in situ. Now my purpose is I have to go into main cancers. Now forget in situ. Let's go into proper cancers. I know the main cancer is ductal cancer. That photo doesn't come. Variants of ductal cancer are asked a lot. So this is one variant where they tend to ask you mucinous or colloid carcinoma. I know mucinous, lots of mucin. Outside also you will see a lot of mucin. Inside the cells also you will see a lot of mucin. So if you look into it, you will see that there is background. Look at the background. If I can shade it, the background is all khali. Because this is like a water pool. This is a pool or a swimming pool of mucin. There are pools of mucin noted, and you will see the tumor cells will be floating in those pools of mucin. So please remember, the mucin can be outside the cells also, or in simpler words, the mucin can be extracellular also, the mucin can be intracellular. Water all around, mucin all around. But that is what you see on a biopsy. What do you see on an FNSC? We see the famous chicken via blood vessel. अब इतना ज़्यादा mucin है ना, All you've seen now everyone uses wireless earphones, but once upon a time we used to use those wired earphones, and all the wires used to get entangled. Na? Same way, if you notice, all the blood vessels over here have gotten entangled. This is known as the chicken wire blood vessel. This is the chicken wire blood vessel, all of them getting entangled like this. Very important question. Chicken wire blood vessel is seen on the FNAC of which breast tumor? Mucinous or colloid carcinoma? Mucinous will tell me lots and lots of mucin. The next one is a surgery exam favorite. It's a type of ductal cancer known as inflammatory breast cancer. What is inflammatory about it? It's not inflammatory, it's a cancer. But why am I calling it inflammatory? Because look at the skin. The skin is looking like an orange peel. So I want to call it the very famous peau d'orange appearance, right? And this is referred to as inflammatory. So why is this skin appearance coming? Because the cancer has infiltrated which part? This is a previous year question. The cancer has infiltrated the dermal lymphatics. The cancer has infiltrated the dermal lymphatics, and that is why this skin, lymphatics mein gaya, that is why the skin is looking like that orange peel appearance. Inflammatory breast cancer, very bad prognosis. All of these were ductal cancers. I know all of you are also waiting for the famous ILC, invasive lobular cancer. And invasive lobular cancer, the cells will be present one behind the other. Indian file, like Indian army men, very disciplined. They are always, if you tell them to stand in a line, they'll be totally standing one behind the other. So same way, Indian army men ki tarah, these cells are standing one behind the other like this. That is the Indian file pattern that you see in invasive lobular carcinoma, for which of course they're going to ask you the genetics. Please note, the genetics is loss of E cadherin, which I have told you so many times. Loss of E cadherin is going to be seen in invasive lobular carcinoma. Okay, all these cancers are done, but what is their immunohistochemistry? For all of these cancers, we do estrogen receptor, progesterone receptor, and HER2/neu, ER, PR, HER2/neu, right? So please note, ER and PR, where do you see the brown color? In ER and PR, I see the brown color is coming in the nucleus, hai na? Receptor, the estrogen progesterone receptors are nuclear receptors. Whereas HER2/neu, the brown color is coming in the membrane. The brown color of HER2/neu is coming in the membrane over here, right? So please note, ER, PR, HER2/neu is what is the immunohistochemistry panel. Why am I teaching you this? Because I want all of you to quickly tell me what is that classification that you do. Jaldi se, I've taught you in too much of detail earlier. Abhi we are going to do it in 30 seconds. On the basis of ER, PR, HER2/neu, we say luminal A, luminal B, HER2 rich, and triple negative. So triple negative to common sense. Everything is going to be negative. HER2 rich also common sense. Only HER2 will be positive. अब इसमें only HER2 is positive, तो luminals में only ER, PRs are positive. उल्टा हो गया, so simple. So ER, PR में positivity, these are the luminals. HER2 rich में only HER2 and triple negative, so everything is negative. So I realized the luminals are looking almost the same. Both of them are ER, PR positive, HER2 negative. So we came up with another marker called Ki67. Less than 14% is luminal A. And more than 14% is luminal B. What is Ki67? Ki67 is a proliferation marker. It is a proliferation marker, right? Okay, so now if you tell me that which cancer will come under which category, please note the way you write triple negative, NE, so dono ME wala things are gonna come. Medullary carcinoma breast, metaplastic carcinoma breast. So triple negative mein dono ME wala medullary and metaplastic will come. HER2 rich mein what will come? Everyone is, so her, why only her, him also, everyone is happy. Whenever someone gets rich, na, that person becomes happy. So Apocrine carcinoma yaad rakhna. Apocrine is gonna make it rich. Apocrine carcinoma means happy to be rich. Happy to be rich. So Apocrine carcinoma is gonna be a HER2/neu rich. Rest everything else, dustbin. Luminal A. Tubular carcinoma, mucinous carcinoma, papillary carcinoma, invasive lobular carcinoma, everything comes under luminal A. Only if I add the word high grade in front of any of these, if I add the word high grade, that will come under luminal B. Why? Because I just now told you luminal B has a higher proliferation marker, more than 14%. So all high grade things will come here. Repeating, NE is going to be all ME. Apocrine is happy to be rich, so HER2 rich. Everything else comes under luminal A, and only the high grade things come under luminal B. I hope everyone's okay. This was just a quick overview. Moving on further, just finishing the breast pathology images, and that is going to be the next one. Actually, it's on the skin of the breast. That is Paget's disease. This can occur in the breast also, which we will call as the mammary Paget's. This can also occur outside the breast in the vulva, extramammary. That is referred to as extramammary Paget's. Guys, there is a Paget's in the bone also. वो ये Paget's नहीं है. That is different. Okay, focus on the Paget's in the breast and the vulva as of now, and you will see the skin will show you a lot of crusting. So actually, patient might go to a dermatologist thinking that the skin of the nipple areola is showing crusting. But when the dermatologist will get a biopsy done, the skin will show you cancer cells. The skin is going to show you these clear looking cells called cancer cells, and that is what is going to tell you that, oh, this is not some kind of crusting or dermatology condition. This is actually something to do with breast cancer. So there is a cancer below. There is a cancer below that has gone into the skin. There is a cancer below that has gone into the skin. So this will tell you this is a cancerous condition. That is what is Paget's disease. That wraps up all of your breast pathology images also. FGT, MGT, breast is done. The next chapter that we take up now is going to be the endocrine system. Under the endocrine system, of course, we start primary is going to be thyroid and adrenal gland. Under thyroid, identify the normal. For everything, I started with normal because I know the importance now of how many normal images are coming to you. So this is how the thyroid follicles are going to look like. These are the thyroid follicular cells. What is that pink material in the center? The pink material is going to be the colloid, right? So you have the thyroid follicular cells with pink material that is referred to as colloid. But also, do you see a cluster of different looking cells over here? That is the parafollicular C cells. Guys, what do parafollicular C cells produce for us in physiology? It produces calcitonin. So I have put an immunohistochemistry brown na? So I've put an immunohistochemistry for calcitonin, and I can see so many of these parafollicular C cells. So theek hai? These are the thyroid follicles. These are the parafollicular C cells, and parafollicular C cells make calcitonin. Let's start with, if I do FNAC, we all know they ask you what is the adequacy criteria for FNAC. Firstly, who gave you the adequacy criteria for thyroid FNAC? There is a group which we know as the Bethesda system. There is a Bethesda group which told us that you should see at least 6 groups, 6, 10, 6, 10. I have learnt it as 6, 10, 6, 10. What is this? Abroad mein there are stores called 7-Eleven. I had learnt it 6, 10, 6, 10. तो क्या 6, 10 है? How many groups should you have? At least 6 groups. Count करते हैं. 1, 2, 3, 4, 5, 6, 7, 8. Many groups are there. So minimum 6 groups should be there. And every group should have at least 10 cells. I don't think I need to count. 10 se to zyada hi hai, right? So 6, 10 means there should be 6 groups and each group should have 10 cells. So 6, 10, 6, 10 yaad rakhna. That is going to be your adequacy for thyroid FNACs. Now let's start with the disease. The first one, of course, that I have to start off with is going to be Hashimoto's thyroiditis. It is an autoimmune disorder, HLA, DR3, DR5. So much that we can even revise with the help of our images only, right? HLA, DR3, DR5 ka association. And what you see grossly is everything of the thyroid will be enlarged. The entire thyroid is diffusely enlarged. And what is microscopically? I see 2 things. Ab dekho. Thyroid hai, so I will have to see the pink color thyroid follicles. All these pink color things are thyroid follicles and colloid. So thyroid word I've understood. But what is this itis word? Itis means inflammation. Which inflammation? Look at this. ये जितना भी lymphoid follicles हैं, that is the inflammation. So thyroid and itis. Thyroid is thyroid follicles. Itis is lymphoid follicles. So दोनों type का follicles are going to be seen. That is why, guys, later on, what do you study? Hashimoto's thyroiditis can give rise to 2 cancers. That will make sense. The first cancer is going to be papillary carcinoma. Thyroid wale part se what will arise? Papillary carcinoma. Lymphoid wale part se lymphoma. That lymphoma is known as maltoma. So these are the 2 cancers that can arise from Hashimoto's. Finally, what is this very, very big pink color cell that I'm suddenly seeing? H for Hashimoto's, H for hallmark, H for hurdle. What is the hallmark of Hashimoto's thyroiditis? So remember, the hallmark of Hashimoto's thyroiditis are these big cells called hurdle cells. Okay guys, so big thyroid overall with thyroid follicles and lymphoid follicles. So thyroid se PCT hoga, lymphoid se maltoma hoga, and big cells called hurdle cells are the hallmark of Hashimoto's. This was Hashimoto's. The next one, the only thyroiditis which is going to be a painful thyroid is De Quervain thyroiditis. Patient always comes to you with pain. I hope you remember this is associated with some kind of viral infection. Post-viral it happens and there is too much of pain that my patient will say. But do you know what is the other name for it? It is granulomatous thyroiditis, which tells you I'm seeing giant cells. Tabhi to I'm seeing giant cells because it is a granulomatous condition, that is de Quervain thyroiditis. All of these, if you remember, whether Hashimoto's or you pick up de Quervain, the thyroid activity is decreasing. They are all hypothyroid because now I'm going to shoot it up. The thyroid activity is going to increase, and you can see that radioactive iodine uptake. Dekho, normal thyroid ka dekho and see what has happened, how the thyroid activity has gone up. This is a case of hyperthyroidism, right? And hyper means you will see everything is going to be very red and hyper. So if you see what is the color of the thyroid is going to be a beautiful beefy red color. Okay, I will do FNSE, I will put needle into it. So needle may be something red, fiery is happening. So if you zoom in, you will see that you can see these, these fire flares. Can we all see these reddish, pinkish color flares that are forming? I'm seeing the presence of fire flares. When I do a biopsy, what will I see? Scalloping colloid. Matlab, it as if you take ice cream out na, from a scoop. Someone is trying to eat the colloid. Someone is trying to eat the colloid. So that is what I said na, ye pura is all about being very hyper. That is what is Graves' disease. Very grave to be hyper. Hyperthyroidism hai. The color of the thyroid is also very, very hyper. Red wala color ho gaya. Iodine uptake has also become too much because it's hyper. The FNSE is also showing me something very scary, that is these fire flares. The biopsy is also showing me something eaten up, right? That is going to be scalloping colloid. These are all the features of Graves' disease. I know what you're waiting for, thyroid tumors. So yes, we are starting with the thyroid tumors, and the first one has to be papillary carcinoma thyroid. So what is papillary? 5-6 features that I'm going to tell you. Papillary carcinoma, of course, means papillae dikhega. So I can see one papilla over here, which is a previous year question. But I always say true papilla hota hai, not pseudo papilla. True papilla is seen in papillary carcinoma thyroid. Means any papilla that has a fibrovascular core is going to be a true papilla. So you will always see something going in it. You will always see something going inside it. That is a true papilla. What is the famous appearance of the nuclei? Khali nuclei, just like these cartoon characters, Orphan and Annie. Orphan Annie cartoon character had white eyes, na? The cartoonist did not draw the eyes. So the nucleus is also all khali, right? All empty nucleus is going to be seen. That is the Orphan Annie nucleus. I hope you remember, it is a formalin artifact. It is only seen because of formalin. So that is why this is going to be seen only on biopsy. Will you see it on FNSE? Nahi. On FNSE, I don't use formalin. When I don't use formalin, I will not see this. On biopsy, I use formalin. That is why I see it on biopsy. What next? We are going to see inclusions, guys. We are going to see intranuclear inclusions that you can see over here. We are also going to see coffee bean appearance. You can see the nucleus is becoming like a coffee bean. And also, of course, any papillary tumor that my concept says will always show me a samoma body. So do you want to summarize? What all did you see in a case of papillary carcinoma? Number one, you saw all the true papillae. Then you saw these empty nuclei called Orphan Annie. Then you saw inclusions, that is intranuclear inclusions. You saw the coffee bean appearance, and you saw samoma bodies. That is what makes up papillary carcinoma. Hope you remember that the most common mutation is BRAF V600E, and prognostically it's a big smile because it has an excellent prognosis. Now, all of this was biopsy. Kuch aisa hai that you only see on FNSE in papillary carcinoma. Again, something important for INICET. Please note, papillary carcinoma on FNSE, basically the colloid, someone is stretching the colloid. The patla sa needle, na, FNSE is a needle, the colloid gets stuck. So this is going to be stretching out colloid. That is a chewing gum colloid that you're going to see only on FNSE. Only on FNSE, we see chewing gum colloid in papillary carcinoma thyroid. Papillary carcinoma done. I hope we are ready for the next one, and that is the follicular carcinoma. What is the criteria for follicular carcinoma, guys? The two invasions have to be seen. Number one, you will see, dekho, ye capsule hai, and it has been invaded. Number one criteria, capsular invasion. Second, the blood vessel. I can see cancer is sitting inside the blood vessel. So second criteria is vascular invasion. So for the diagnosis of follicular carcinoma, you need capsular and vascular invasion. The two questions that you get: what is the most common mutation that you see? Is the RAS mutation, and can you give this diagnosis on FNSE? Can it be diagnosed on FNSC? No, cannot be diagnosed on FNSC. The only thyroid tumor which I cannot give a diagnosis on FNSC is follicular carcinoma. Why? Because on FNSC I cannot see capsule and blood vessel. Jab dikhega nahi, to how will I give the diagnosis? Only give a diagnosis on biopsy. Coming to the last one in the thyroid tumors, and that is medullary carcinoma. I hope you all know. They will ask you the tumor marker for medullary carcinoma, which is going to be calcitonin. And we know that calcitonin will end up getting deposited as amyloid, A-cal wala amyloid. So that is why over here I said ye amyloid hai. You said, "Arey ma'am, everything in pathology looks pink. Why are you saying ye amyloid hai? Prove karo." Okay, I'll prove it with Congo red. What do you see on Congo red? We see the very famous apple green birefringence. And apple green birefringence is seen on which microscopy? It is seen on a polarizing microscopy, right? So polarizing microscopic examination shows you apple green birefringence. Thus I know it is amyloid. Which kind of amyloid? Calcitonin wala, because medullary carcinoma produces calcitonin. That marks the end of all of your thyroid images. Now you're left with two more images that will finish off your endocrine system, because now you're going to go on to the adrenal gland. And the first adrenal gland tumor that you have to know is neuroblastoma. But there's not much to teach you. I've taught you. I've already taught you in the brain chapter only. We studied something called Homer Wright pseudorosettes. Remember? I said that there's going to be some pink material in the center. That is why you're calling it a pseudorosette. And I told you that, okay, the men tumors have Homer Wright pseudorosette. Men are pseudo, men are right, men are fake. Hai na? So medulloblastoma, pad liya. Neuroblastoma, you're studying right now. And Ewing sarcoma, you will study in the bone. So these three, medulloblastoma, Ewing sarcoma, neuroblastoma, they show you Homer Wright pseudorosette. But genetics batao. N for neuroblastoma shows you what? It shows you N-MYC amplification. N-MYC is going to get amplified. You will say, oh my God, one gene is going to get amplified. Fit kahan karenge, ma'am? Where will we fit? So much of gene will come. I'll say, nahi fit ho raha, never mind. This is, make two separate dots out of it. Alag kar do. If you can't fit it, if this is your chromosome, you can't fit it over here, put it outside. So if someone comes to your house, what will you do? Either you will make place for that person to sleep in your house, or you will send that person to some hotel. So abhi I said send him out to a hotel, and that is known as the double minutes. That is why I was drawing those two dots. So can I say it is outside the chromosome? Whereas you say, no ma'am, they are my very close relatives. I can't make them stay in a hotel. I will have to make N-MYC stay in my house. So I'll say, fine, make place in the same chromosome, make place for this. Means this is HSR, homogeneously staining region. So this is important only for INI-CET. Please remember, neuroblastoma shows you lots of N-MYC. Where should I fit the N-MYC? Either I make him stay outside in a hotel called double minutes, or I fit him inside my house. That is known as homogeneously staining region. Neuroblastoma done. The next adrenal medullary tumor that you have to know is pheochromocytoma. Very famous for 2-3 points. You know that pheochromocytoma is a neuroendocrine tumor, and that is gonna obviously involve the famous pattern called nests. Aisa round nest banega. But over here, the nesting pattern is called as Zellballen pattern. 10-star question. Very, very important. The nesting pattern is known as Zellballen pattern, and because it is a neuroendocrine tumor, every neuroendocrine tumor shows you the same thing under the electron microscope. On electron microscopy, you will be seeing these big round black things called neurosecretory granules, which I have shown you for every electron microscopy in every neuroendocrine tumor. So if you see the Zellballen pattern with the neurosecretory granules, you know you are dealing with pheochromocytoma, and that follows the very famous rule of 10. Quick revision. 10% of them occur bilaterally. Where do they occur? See, adrenal gland hai to 10% of them are going to be in both the adrenal glands. 10% of them occur in children. 10% of them might occur outside the adrenal gland, and when they occur outside the adrenal gland, you will call it paraganglioma. 10% of them might spread, might be cancerous, and 10% of them do not cause hypertension, because most of them definitely cause hypertension, only 10% do not. Earlier they used to say 10% are familial, but no, now they say 25% are familial. So familial has been removed from the 10% rule. Rest everything else, it is bilateral in children, malignant, extraadrenal, and does not cause hypertension. All of that is 10%. Familial is not 10%. Pheochromocytoma also done. So your adrenal gland is over, means your endocrine chapter is also done. Now the images in systemic pathology left are for bone as well as skin pathology. Let's begin with the last two chapters that we have in systemic pathology, which we are going to quickly rush through because they're two independent subjects, that is ortho as well as dermatology. Let's start first with the bone tumors. Before I begin, I've got you a brief introduction about how we divide the bone tumors. So quickly going through the same. Epiphyseal, metaphyseal, diaphyseal. Epiphyseal, we have mnemonics for each. So epiphyseal mnemonic, GCT. What is GCT? G stands for giant cell tumor, which is epiphyseal. C stands for two things, and that is going to be chondroblastoma and clear cell variety of chondrosarcoma. Not the original conventional chondrosarcoma, but the clear cell variety of chondrosarcoma. So giant cell, chondroblastoma, chondrosarcoma, clear cell variety. What is metaphyseal? So now there's a mnemonic for that. Me. So how do you study? First you think every day in the morning in a very dedicated way that I'll study on the table and the chair, but eventually you slip into the sofa or the bed, right? So me studying on a sofa chair. So remember, me studying on a sofa chair. So what is it? First we have two cysts, simple bone cyst, aneurysmal bone cyst. Then we have the main tumor of the bone, that is osteosarcoma, a bone tumor like condition, that is fibrous dysplasia, and chair say there is osteochondroma, not just chondroma, osteochondroma. So repeating, the two cysts we have, simple and aneurysmal, main tumor osteosarcoma, fibrous dysplasia, and osteochondroma. Coming to diaphyseal. How do we learn diaphyseal? Diaphyseal sounds like dad. So dad is a male officer. Of course, dad is going to be a male officer. So a lot of hemat tumors come here. M say there is multiple myeloma and L say there is leukemia. So multiple myeloma and leukemia done. Then we have A for adamantinoma, which is a tumor in the tibia if you remember from the orthopedics. E for Ewing sarcoma, which is the most expected question for diaphyseal tumors. And officer is OO, that is osteoid osteoma. So repeating, epiphyseal के लिए GCT, metaphyseal me studying on sofa chair, and diaphyseal dad is a male officer. Now out of all of these, as I told you, the main one is osteosarcoma. So here we have a picture of osteosarcoma. We have the radiology also, which shows you very characteristic a triangle form, that is Codman triangle. What is Codman triangle? What is this layer? This is going to be the periosteum. This is the periosteum which has been lifted. This part of the triangle is the shaft of the bone that you have, and obviously then I draw an imaginary line. So there is a periosteum, there is a shaft of the bone, and then there is an imaginary line that makes it a triangle. Also, osteosarcoma means osteo, a lot of bone production. You will be able to see that bone production in the form of a sunburst or a sun ray sunburst kind of an appearance. And the same osteoid you will be seeing under the microscope. So all this pink material that I'm seeing all throughout, how do you define osteoid? It is thin, pink, lacy, glassy. That is how, as a rhyme, I have learnt it. That osteoid is going to be thin, pink, lacy, glassy. That is what makes it osteoid. Now let's move forward. This was about your bone tumors, bone forming tumor. Now I want all of you to know the cartilage forming tumors. Under cartilage forming tumors, first I'll pick up the benign and the malignant. Benign wala is enchondroma and malignant is chondrosarcoma. So the common sense tells me that enchondroma will not have any permeation because it's benign, na? So radiologist will say no permeation. Whereas for chondrosarcoma, radiologist will definitely say permeation because this is a cancer. Second, enchondroma will occur in the small bones. You can see, I'll show you a picture where there will be a problem in the bone of the hand, very chota sa bone. Whereas the axial skeleton, that is pelvis and all these axial skeleton wala involvement is going to be in the malignant one, chondrosarcoma. So let's have a look at the pictures. Let's try to compare the two. The first picture that I have over here, as I said, small bones, and can you see the cortex is intact. The bone has not broken. Yahan se aur yahan se it is intact. This means there is no permeation. This means this is a case of enchondroma. So firstly, what I notice, I see that there is no permeation that is seen, and because it's cartilage, guys, it's black. All of it is looking all black because radiolucent cartilage hai, but I see some dot over here. This means there is speckled calcification also that I can see. Speckled calcification noted, but no permeation. And over here when I see cartilage blue color ka hota hai, so I can see all benign looking innocent wala cartilage that I have under microscopy. That is a benign tumor. Now let's go into the malignant tumor, which is going to be chondrosarcoma. Chondrosarcoma is of course a cancer. So it's going to look very, very dirty. Look at at the cells, they are all malignant cartilage, big cells. These are all malignant cartilage cells that you're seeing. And of course, the radiologist we are very much dependent on, because the radiologist will say that the tumor is invading. That is when I'll say, this is a cancerous tumor. So the two tumors are done, enchondroma and chondrosarcoma. One is benign, one is malignant, right? Now let's move on to what does enchondroma show in its genetics? IDH1 and 2 mutation. Quickly guys, can you revise with me that what is gonna be the... So starting with the genetics of enchondroma. Enchondroma shows you IDH1 and 2 mutation. Do you remember what was the mnemonic for all the IDH mutations? Isocitrate dehydrogenase. I am egoistic. Isocitrate dehydrogenase is I am egoistic. E means the tumor that you're studying over here, that is enchondroma. G and O are two tumors that you have in the brain, which I've taught you, glioblastoma and oligodendroglioma. So remember, I am egoistic. That is how you learn it. Enchondroma, glioblastoma, oligodendroglioma, they show you the IDH mutation. Now coming to the remaining two, let's start with osteochondroma. See, it has the osteo, kuch bone, chondroma, kuch cartilage. Little bone, little cartilage. So the other name for osteochondroma, I'll show you a separate picture, is exostosis. Something is exiting out. Okay? So exostosis ka EX and T if you take, that becomes your mutation. That is EXT1 and 2 mutation. So osteochondroma is known as exostosis. What is exiting out? Ye chota jo photos hai, let us enlarge it. So I will see that there is a bone that is exiting out in the form of a mushroom. That is how they define it. This is a kind of a mushroom, kind of a protrusion. So you will say, what is exiting out, ma'am? Cartilage, your bone, everything. If you see this, the cartilage is going to form a cap. So the cartilage is also going to be a covering, and then the bone is also going to exit, and the bone ka every layer is going to exit. There's going to be exit of the bone cortex also, and the marrow also. So everything about the bone is, everything is exiting. That is why I called osteo for bone, chondro for cartilage, and because everything exits and comes out as a mushroom, exostosis, and exostosis ka EXT. This is also done. Now we left with the last cartilage forming tumor, that is known as chondroblastoma. Now guys, chondroblastoma is known as the Codman tumor. Please note, Codman tumor and Codman triangle are different. Codman tumor is in front of you, and where did you see the Codman triangle? That was seen in osteosarcoma. So what are these three pictures that I've got for you for chondroblastoma? This is their favorite exam question. Chondroblastoma ka 3 pictures, the Codman tumor. Firstly, if you go all the way back, I taught you that this is an epiphyseal tumor. Remember, epiphyseal I told you was GCT mnemonic C was chondroblastoma. Yes, this is an epiphyseal tumor, and you will see lots of giant cells. So the first thing that you notice over here are going to be the giant cells. 3 features I have to tell you. First one is giant cells. Second, if you will zoom in a little, you will realize that there are also cells which are showing you lines inside them. Can we all see the beautiful coffee bean appearance that is coming out? Finally, this is another tumor which is showing you a coffee bean nucleus. That is option number 2, coffee bean nucleus. And third one is the exam favorite. It shows you chicken wire calcification that you have in front of you. So all these are going to be like calcium, like a wire. You've seen this, na? Like the chicken are held by a wire, that way chicken wire calcification. So you will say, very good ma'am, I've understood. Giant cells hai, coffee bean hai, chicken wire hai, but there are so many chicken wires that you've told us by now that we started to get confused. Let's revise. Chicken wire, where all did we study? Right now we studied chicken wire, blue calcification is seen in which bone tumor? Chondroblastoma. If I ask you chicken wire fibrosis, fibrosis was seen, I told you na, with alcohol everyone consumes chicken. That is a way of learning. So alcoholic liver disease mein you see chicken wire fibrosis because alcohol ke saath everyone eats chicken. Okay? So you can see the blue fibrosis here. Then we have chicken wire blood vessels. They are seen in 2 conditions. So number 1, blood vessels are seen in the FNAC of which breast cancer? Mucinous or colloid breast cancer. And they are seen in which? These chicken wire blood vessels are seen in which? Brain tumor. I told you the brain tumor with a lot of andas, the oligodendroglioma. Where there is andas, there is chicken. Remember? So because of fried egg appearance, you also had chicken with it. It shows you chicken wire blood vessels. So repeating, chicken wire calcification, chondroblastoma, chicken wire fibrosis in the liver, of course, chicken with alcohol, then chicken with egg. So jahan fried egg appearance hai, wahan chicken wire blood vessels. And finally, in the FNAC of mucinous or breast cancer, That is going to be again chicken via blood vessels. Okay, so this is another tumor done, which means all of your, congratulations, all of your cartilage tumors are done. What do we move on to next? Two more main tumors are left. The first one I'm sure you identify very well because you've seen it in every exam question. Ewing sarcoma. What did I tell you? Dad is a male officer, so Ewing sarcoma is going to be a diaphyseal tumor, right? And please remember, this Ewing sarcoma tends to show you translocation 1122. It is the EWS Fly1 fusion, and I gave you a mnemonic for it also. Ewings mein you have the E, that is going to be 11, and S ko flip karo, that is going to be 22. So E is going to be for 11 and sarcoma ka S you flip, so that is going to be 22. 11-22 fusion. And how do you learn the fusion genes? So again you will learn EWS, that makes it Ewing sarcoma, and wings help you fly. So the other gene is going to be fly fusion. So it is an EWS Fly1 fusion that occurs. So let us see these pictures first. How do you see this Ewing sarcoma under the microscope and radiology? You see the very famous onion peel appearance. If you ask me, ma'am, what is this onion peel? What is this layer by layer that is getting deposited? It is nothing but the periosteum. So this is a kind of a periosteal reaction. Next, so many times I have told you that it shows you Homer right pseudorosettes. I am also bored of telling you. I've told you so many times, either men are right or men are fake, hai na? So M was for what? Medulloblastoma. N for neuroblastoma. Finally, we finished the E, that is Ewing sarcoma. This also shows you the Homer right pseudorosettes. And what are they positive for? These cells are gonna be staining for P for pass, P for pink. What stains for pass? Glycogen. This means these cells contain glycogen. That's a previous year question, which is the only bone tumor that contains glycogen positive for pass. That is going to be your Ewing sarcoma. So it is pass positive. Another CD marker that you have to know is CD99. CD99 over here is also known as MYC2. So CD99 or MYC2 is the favorite AIIMS previous year question. It's come a million times. Okay. So CD99 or MYC2, and how I have learnt it is MYC2 sounds like Mithu. Hai na? Mithu is like bachon ka naam. Pet name of kids in our country is Mithu. And Ewing sarcoma is not an elderly tumor. Ewing sarcoma is something that is going to occur in adolescence. It's an adolescent age tumor. So it's an adolescent whose ghar ka naam is Mithu. Okay. So that is how you learn it. MYC2 is going to be positive in Ewing sarcoma. Coming to the last but the most important tumor. So I hope everyone's okay with this picture. There is an onion peel appearance. There is Homer right pseudorosette, pass positive. That is Ewing's. Now let's come to the last tumor. That is giant cell tumor. Giant cell tumor. Benign hai, malignant hai, ma'am, nothing. It is locally aggressive. Neither you can call it benign, nor you can call it malignant. It is hanging in between. So I call it a locally aggressive tumor. So you have three pictures: gross, radiology, microscopy. Zoom in kare. So what do you see in gross radiology and microscopy? This grossly, what do you see? Lots and lots of hemorrhage. Ab imagine if there's so much of blood, how will blood look like on an X-ray? Black lagega. So I can see all these black spaces. That is what gives it a soap bubble appearance. So radiology shows you soap bubble appearance. When I say giant cell tumor, no points for guessing that you are going to see a lot of giant cells. So I can see lots and lots of giant cells. And in between, I see single cells also. I also see single cells. So the question asked is, giant cell tumor mein what is the tumor? Is it the giant cell or that is it the single wala cells? Now that is what is pathology. Now what you read is not what you see. So we believe that giant cell tumor mein tumor must be giant cells, but no, tumor is not the giant cell. The tumor part is going to be the mononuclear cells, and they really like to ask you this question. Do you know a drug in orthopedics that they are trying to give? They are also now trying therapies with denosumab. Denosumab is going to be an anti-rankle drug. Yes, they are trying that for giant cell tumor. So that definitely wraps up all your tumors. Now I'm left with chota miscellaneous things. There is one tumor which is very important for the INI-CET exam, and that is going to be chordoma. So tell me, chord, matlab this is the one that is coming from the notochord. The origin of this is going to be the notochord. So where does this occur? This is either going to occur in the clivus or it's going to occur in the sacrococcygeal region. These are the two sites, clivus and sacrococcygeal region. And what are the two very big names which are very famous for it? It shows you ficelliferous cells. Ficelliferous cells ka simple name. It shows you bubbly cells. If I show you the picture, they'll all have bubbles inside it. Dekho, it has vacuoles, all bubbly looking cells. This one also over here, bubbly cells. This one also over here, bubbly cells. Got you every picture from the internet. So basically it's showing you a lot of bubbly cells, that is ficelliferous cells, and these bubbly cells are positive for brachyury. If I ask you what is the genetics and what is the marker, brown color stain matlab, this must be a case of immunohistochemistry histochemistry. And what is the marker? So remember, the marker is also going to be brachyury and the genetic alteration is also going to be brachyury. दोनों का आंसर brachyury gene है, right? So remember, notochord से chordoma होगा. It's going to have bubbly cells called phycelliferous cells. These bubbly cells have genetics of brachyury, marker as brachyury, and the site is going to be where notochord remnants होते हैं, clivus and sacrococcyx. All the tumors are wrapped up. I also want to take you a little bit into orthopedics and tell you tumor-like conditions. Again, this is also important for INICET. This is a condition known as fibrous dysplasia. This looks like a tumor, is not a tumor. Fibrous dysplasia shows you which kind of deformity in orthopedics. It shows you like a shepherd crook ka wo hanging thing. That shepherd crook deformity is going to be noticed, that you can very well see over here. Also, if you zoom in, the bone is looking very hazy. It's not looking white like a bone. It's looking very, very hazy. So what do you call it? That is known as the ground glass. So एक तो shepherd crook deformity हो गया, and second is going to be the ground glass appearance. What do you see microscopically? You will see the trabeculae are taking weird Chinese letter wala shape. So this shows you Chinese letter, all weird L, and I don't know Chinese letters. I don't know Chinese. So yeah, all these kind of shapes are, I just know that is what is being seen. And Chinese letter trabeculae are noted. Now there comes a confusion for a pathologist, because fibrous dysplasia also shows you these Chinese letters. And the next one, that is non-ossifying fibroma, that also shows you random Chinese letter. How will I differentiate? The rule is only one non is allowed. मतलब if you are dealing with fibrous dysplasia, इसमें अभी non नहीं आया ना, so now you will say there is no will come here. There is no osteoblastic rimming. There is no osteoblastic rimming. Whereas if I'm dealing with non-ossifying fibroma, non has come. This means now it can't come. There is osteoblastic rimming. So only one non is allowed. How do I see osteoblastic rimming? Dekhe. So look at this. If you enlarge the Chinese letter, do you see the periphery has these blue color cells? Definitely. Yeah. So something is rimming them. There are osteoblasts which are making a rim. So osteoblastic rimming is there. Osteoblastic rimming is there. Matlab non ऊपर आएगा. Non-ossifying fibroma. Whereas if I say, look at these ones. Do you see, if I show you this, do you see any cells which are lining it? Nahi ma'am, ye khali lag raha hai. The peripheries are looking all whitish, little khali. There are no proper cells which are lining it. So if there is no osteoblastic rimming, no has come over here. So it can't be non-ossifying fibroma. No yahan pe aa gaya, matlab the disease is fibrous dysplasia. Everyone's understood? Fibrous dysplasia, no osteoblastic rimming, non-ossifying fibroma shows osteoblastic rimming. What are the last picture that you have to know? It's again a cyst known as aneurysmal bone cyst. So again, aneurysmal will tell me that it's going to have a lot of blood in it. And around the blood, there are going to be lots and lots of giant cells. So simple si baat hai. If there is a lot of blood under the radiology, it is going to look radiolucent. Common sense, because there is a lot of blood. And when I look at this under the microscope, of course, ma'am, as you said, I'm seeing lots and lots of blood, all red color blood. And you said along with blood, I will see giant cells. So yes, I can see giant cells also. Very, very nice. So this is so important. This is showing you giant cells. This is showing you blood. Can I confuse it with a giant cell tumor then? हो सकता है, can happen. I can, as a pathologist, I'll see giant cells. I will confuse it with giant cell tumor. But guys, giant cell tumor was what in location? Epiphyseal. An aneurysmal bone cyst was coming in that sofa chair mnemonic. Me sitting on a sofa chair, it is going to be metaphyseal. So that is why I said the first slide is the most important for you guys. Bone tumors are done. Bone tumors के साथ soft tissue tumors भी आता है. Do you want to quickly revise them? Okay, so now this is again important for INICET exam. There is a soft tissue tumor known as fibrosarcoma. Fibrosarcoma is very famous for showing you the herringbone pattern. Herringbone is a fish. तो fish का जो spine होता है, that is what they are referring to over here. So if you see the cells, they are going in a pattern like this. That is the herringbone pattern is seen in fibrosarcoma. Coming to the next, where do you see, or what is the smooth muscle tumor known as? A smooth muscle cancer. So that is going to be leiomyosarcoma. And I've already told you, anything smooth, cigar is very smooth. Anything to do with smooth muscle is going to have cigar-shaped nuclei. You will see nuclei which are looking exactly like a cigar over here, or blunt nuclei. So cigar is very, very smooth. That is why you call it smooth muscle cancer. Please note, they will ask you the markers. पहले तो every sarcoma, I've taught you in neoplasia chapter, every sarcoma is going to be vimentin positive. But because this is a smooth muscle sarcoma, it is smooth muscle actin also positive. So the ओवरऑल थिंग इज वाइमेंटिन प्लस स्मूथ मसल एक्टिन। तो ये तो स्मूथ मसल ट्यूमर था। आई एम ऑल्सो इंटरेस्टेड इन अ skeletal muscle tumor. What will you call it? Rhabdomyosarcoma. So again, rhabdomyosarcoma ka which variety have I showed you? Embryonal variety, happens in chota bacha and is known as sarcoma botryoids. So sarcoma to I have understood. Okay, what is this botryoids? Botryoids means it looks like a grape-like cluster. A grape-like, it will occur on all mucosal surfaces, like it can occur in the vagina, it can occur in the nose, mucosa se arise hota hai. So sarcoma botryoids, botryoids refers to grape-like clusters. And the most famous question, what does it show you? It shows you a cambium layer. Cambium layer is something which has lots and lots of cells. Cambium layer is going to have lots and lots of cells, and below that you can see there are no cells. So all the cells are accumulated in a layer known as a cambium layer. How are the cells going to look like? If you zoom in, you will realize the cells are looking like a racket. The cells are looking like a racket over here. So you call it a tennis racket or a strap cell. Tennis racket or strap cell. So remember, rhabdomyosarcoma shows you racket cells. They will ask you this. Rhabdomyosarcoma shows you racket and rap. Rap. जैसे याद करना, ठीक है? So rhabdomyosarcoma shows you rap, that is strap cells, shows you racket cells. That is very important for you to know. But still you say, fine ma'am, I saw the sarcoma botryoids, I saw the cambium layer, I saw the strap cells, but I still want you to confirm it. The special stain for skeletal muscle that you can use is PTAH. I know I'll tell you the full form, but then no one learns it by the full form. Full form stands for phosphotungstic acid hematoxylin. Phosphotungstic acid hematoxylin. Basically hematoxylin hai, but a different variety. And we tend to forget. So tell me guys, skeletal muscle is used for what? Skeletal muscle is your strength. It is used for pitai. You should not do that, but skeletal muscle is strength. It is used for pitai. And what is the stain sounding like? It is sounding like pitai. So this pitai stain, PTAH stain, is the one that I'm going to use for skeletal muscle tumors. Next, what is the IHC that you will be using? You will say, ma'am, ek to abhi you told us that every sarcoma will be vimentin positive. So let me add that. But this time it is not smooth muscle. This time it is skeletal muscle. So skeletal muscle ke liye you have desmin and you have MyoD1. These are also previous year AIMS questions. There is going to be desmin and MyoD1. ठीक है? तो sarcoma word सुनते ही vimentin. If it is a smooth muscle sarcoma, you put smooth muscle actin. If it is a skeletal muscle sarcoma, you put desmin and MyoD1. Also, by now you studied so many tennis rackets in path and micro. तो जल्दी से should we revise? What is the tennis racket that I just taught you? So remember, if they say tennis racket and they ask you that what is the tumor, you will say rhabdomyosarcoma में tennis racket cells होगा. Next, where do you see the tennis racket appearance? Electron microscopy pe, the very famous Langerhans cell histiocytosis, right? Langerhans cell histiocytosis. Next, coming to microbiology, which parasite can look like a tennis racket? We all know this angry man. That angry man is known as Giardia lamblia. And which bacteria can look like tennis racket? Now again, you can see spore forming wala. So some students say Clostridium tetani, Clostridium tertium. Ma'am, confusion ho gaya. So Clostridium tertium has tennis racket in it. ठीक है? Clostridium tertium has tennis racket in it. So tertium में tennis racket appearance दिखता है, not in tetani. Simple. So remember, rhabdomyosarcoma, LCH, Giardia lamblia, Clostridium tetani, they all show you tennis racket from path and micro. Soft tissue also done. Why should we leave the joints? Quickly, let us do the images for gout and pseudo gout. And you already know this. This was the recent FMG 2023 question in January. So please remember that gout is going to show you what crystals? Uric acid. And pseudo gout shows you CPPD. So सबसे पहले uric acid is going to look like a needle. It is going to look like a needle and it is negatively birefringent. So remember, uric acid is going to look like a needle and is going to be negatively birefringent. Whereas CPPD is going to be rhomboid and it is going to be weakly, little positive. So weakly positive birefringent. So when you see these rhomboid crystals, you know that okay, rhomboid crystals with little positivity is going to be a case of pseudo gout. Okay? So please remember, gout is always the main one na, that we study. Pseudo gout to second disease है, gout is main one. तो gout में क्या होता है? Uric acid and बिल्कुल needle like crystals, any needle like crystals are negatively birefringent. Remember, needle like crystals are negatively birefringent, whereas the rhomboid crystals are weakly positive birefringents. Sorted? Even the joints are sorted for you. Gout tends to occur in the toe, great toe, the first metatarso-phalangeal joint, or we always learn it as the great toe, right? That is where the tophus occurs. muscles, whereas pseudo-gout tends to occur in a little bigger joints like the knee joint. Yes, we've wrapped up our discussion of bone, soft tissue and the joint images. We are only left with one chapter, and that is going to be the skin pathology. So let's discuss the last part of the systemic pathology, and that is skin. Let's start with the most famous disease, that is psoriasis, which presents to you with these scaly silvery scales, and I can see those silvery scales, but if you remove those silvery scales, you see a lot of reddish base underneath, right? So yes, that is the clinical part, but what you actually get a question on is going to be the microscopy. So microscopically, I can see lots and lots of keratin. Lots and lots of keratin is going to be referred to as hyperkeratosis, right? After that, I can see that there are nuclei also present in the keratin. When the nucleus is present in the stratum corneum, we call it parakeratosis. So yes, I can see an element of parakeratosis also. If you want, you can zoom in and see all throughout. In the topmost layer, you're seeing a lot of nuclei. All of these indicate that there is parakeratosis. Finally, we see the most essential thing, that is Munro's microabscess. Munro's microabscess is nothing but a collection of neutrophils in the epidermis. So that abscess wala thing comes. It's a collection of inflammatory cells. I hope you're not getting confused. Munro's and Potrier's are two separate things, and you had to follow the PMMP. What is PMMP? You have to keep a combination of P and M. So if P was asked, that is Potrier's microabscess was asked, your disease should have been with M, and that is mycosis fungoides, which you studied in the hematology section. Whereas if you are asked M, that is Munro's microabscess, your disease has to be with P, and that is going to be psoriasis. So remember PMMP. One disease is done. The next skin disorder that we have is going to be lichen planus, which is identified in skin dermatology. You study that 6 P's, na? Planar, polygonal, purple, yes. So now we are going to see the most essential thing, that is you see these white lines, and those white lines are known as Wickham's striae. That is how you identify lichen planus. And what do you see microscopically? Your epidermis has changed into a sawtooth. That is a sawtoothing appearance that you notice first and foremost. And secondly, you will appreciate there is a blue color band, an entire blue color band of ... cells that are present. So those are going to be band-like lymphocytes. That appearance is band-like. So lichen planus shows you lymphocytes, and it shows you these lines. I've learnt it as lines. So lichen mein kya dikhega? There are going to be lymphocytes and lines. That is Wickham's striae. I hope you've got the mnemonic right. But that's not over. Apart from that, lichen planus shows you some very essential bodies which I have taught you in the very first chapter. That is the colloid or the civet or the cytoid. These are CC wala bodies. What exactly are those? These pink bodies, they were elements of apoptosis which we had studied. They are apoptotic bodies. They're going to die. The cells are eventually going to die. So imagine if the cells dies, finally if it dies, what will be left over here? You will say, ma'am, if the cell will die, you will be left with a whitish space. You will be left with a space. Once it will vanish away, that space, like you can see some white spaces here, that space will be known as the Max Joseph space. So when there is a body, a dead wala body, you call it a colloid or a civet body or a cytoid body, any CC wala body, and that is an element of apoptosis. When that body will die away, a space will form, and that is Max Joseph space. These are all features of lichen planus which are very important. Next one is a very famous infection which you always get a question on, and that is molluscum contagiosum. Firstly, you have to identify the clinical aspect. You can see that there are umbilicated papules. Umbilicated matlab, you will see a central depression. You can see something getting dipped inside it. There is an umbilicated papule. What else? What will I see microscopically? Look at this. You're seeing a cup-shaped lesion. Yes, the next feature is a cup-shaped lesion over here, which you can see, and inside that, can you see all these pink color bodies? Those are the most famous question, that is known as the Henderson-Patterson bodies. And guys, they will ask you in dermatology also, what is the stain for the Henderson-Patterson bodies? And that is going to be floxine tartarate stain. Let's move on further. Molluscum contagiosum, 20-star question if I can say so. These umbilicated lesions with cup-shaped lesions, with HP bodies, with floxine tartarate positivity, every word is important. And of course, you know the virus. It is Molluscum contagiosum virus, which belongs to the pox virus family in the DNA viruses. Now let's move on to the last part of skin, almost last, and that is bullous disorders. I've tried to make a list so that life becomes a little easy. These are all the bullous disorders that I have to know. First two, that is pemphigus are going to be in the epidermis, top layer. And the next three, bullous pemphigoid, EBA and dermatitis, are subepidermal. So ये तो clear हो गया that almost everything is going to be a subepidermal bulla. Only these two pemphigus are going to be somewhere in the epidermis. So first, let me show you a picture of this. Look at this, guys. There is a problem in the epidermis, topmost layer. So in pemphigus vulgaris, there is a suprabasal split. You देखो, the basal layer is as it is. Basal layer is standing as it is, not moving, but above the basal layer, there is a split, suprabasal split. So this layer which is standing or as it is referred to as the row of tombstone appearance. Like stones are standing, so the basal layer is standing, but everything above it is split. That is pemphigus vulgaris. Whereas what is pemphigus foliaceus? Remember, foliaceus में सब कुछ first होता है. The first layer is split. Corneum, below the corneum there is a split, so the first layer is split and that is known as subcorneal split. In both of them, which kind of immunofluorescence you get? You get a kind of a fishnet, as if a net has been laid on top. So coming back, this is going to be pemphigus vulgaris is suprabasal, and foliaceus में first layer में problem है, that is subcorneal. Not just that, please note both of them tend to show you the fishnet appearance. And what is their problem? What is their etiology? Pemphigus foliaceus में only first desmoglein is affected. DSG for desmoglein. Remember, only the first desmoglein, because foliaceus had to be the first layer and the first desmoglein, whereas vulgaris is going to be both desmoglein 1 as well as desmoglein 3. Now let's come to the other three. All three of them are subepidermal, subepidermal, subepidermal. How will we differentiate? So first let me show you. This is how you differentiate a bullous pemphigoid with epidermolysis bullosa acquisita. You will say, okay ma'am, दोनों में I can see a cavity, but their immunofluorescence that I see, एक में the green color is coming ऊपर and एक में the green color is coming नीचे. So on both of them, the green color is like a line, that is a linear pattern. But in bullous pemphigoid, देखो God is always above. So the line is always present along the roof of the bulla. The line is always present on the roof of the bulla. Whereas epidermolysis bullosa acquisita, aqua is always on the ground. Water is always on the ground. So what you're going to see, the green color line is going to be on the floor of the bulla. हो गया easy. Bullous pemphigoid में the green color is seen, God is above on the roof and aqua is on the floor on the ground. So that is how you learn it. So here you've done a case of bullous pemphigoid subepidermal and epidermolysis bullosa subepidermal, and in both of them, obviously you must be wanting to know the genetics. तो बहुत simple है. Bullous pemphigoid का BPAG antigen, bullous pemphigoid antigen. For epidermolysis bullosa acquisita, remember there is a collagen 7 problem. But दोनों में you have learned, one is along the roof, one is along the floor, and that is the difference. Coming to the last one, dermatitis herpetiformis. This is also subepidermal. But remember, I have learned dermatitip herpetiformis because dermatitip is going to show you the presence of tip lesions. You see these tips over here. So remember, dermatitis is going to show you dermatitip, and what is it? This is a tip lesion showing you which antibody? Showing you IgA antibody. That is the reason that because dermatitis shows you IgA antibody, it is associated with a disease in the intestine which shows you IgA antibody, and that is going to be the celiac disease. This entire thing that I've got over here is your bullous disorder to go-to point. So repeating, the first two are going to be in the epidermis, suprabasal and subcorneal. Foliaceus is first layer, first desmoglein. Both of them are going to have fishnet. Then we have three things which are subepidermal. Dermatitis is going to show you tip lesion with IgA. Bullous pemphigoid is going to go God, so linear along the roof. Acquisita, aqua, linear along the floor. Bullous pemphigoid is BPAG antigen, and epidermolysis bullosa acquisita is collagen 7 defect. The last thing in systemic as well as in skin pathology that you're left with is the famous basal cell carcinoma. I hope you remember that in dermatology you study it very commonly along with Gorlin syndrome, and that is going to show you this very famous pearly nodule. Look at its margins are all rolled. There are rolled margins, and can you look carefully that there is a blood vessel on its surface? Telangiectatic blood vessels. Please remember, we have the presence of pearly nodule with rolled margins and telangiectatic vessels, and what are we going to see microscopically? The cells are present all in a line like this. That is known as, the cells are present back to back, parallel. That is known as peripheral palisading. So we'll take the two words separately so that you don't have any confusion. there is going to be peripheral palisading and there is going to be retraction artifact. So देखो, peripheral palisading मतलब, peripheral palisading means that they are all back to back parallel to each other. And what is retraction artifact? Retraction artifact means I can see a retraction, there is a white area present. For example, if these are the cells, they are retracted, they have tried to pull back, that is a space created. So remember, they ask you which skin tumor shows you peripheral palisading with retraction artifact and a pearly nodule. Very commonly over here, that is going to be the medial canthus of the eye, and that is a classical basal cell carcinoma, right? And you've known it is the Gordon syndrome. Can I ask you one more question? What is the pathway that is defective in Gordon syndrome? It is the SHH pathway. Just, we can go anywhere, but there has to be a stop to it. So yes, there is going to be the end of systemic pathology, and your last part left for images is hematology. Let's begin with the last part of pathology, and that includes our hematology section. Now, under this, we are going to have hemat and blood banking both. Let's begin with the first one, which is the most important image nowadays, and that's the bone marrow needles. So first, the bone marrow aspirate needle. If you see a screw on the side, you are referring to the Salha's needle. So simple. If you see a side screw like this one, it is a Salha's needle. Whereas if you see a longitudinal screw like this one, then it belongs to the Klima needle family, right? So Salha's and Klima, both of these belong to bone marrow aspirate needles. Whereas if they ask you the bone marrow biopsy needle, and that should be the T-shaped needle, whether you see it the reusable or the one-time use one, these are the T-shaped needles that you need to learn. They are known as the Jamshidi's bone marrow biopsy needles. Simple. Let's move forward. Also, I hope you know the site for the bone marrow aspirate and biopsy is going to be posterior superior iliac spine, which is the most common site. The next image that we have is a very important cell that is known as a reticulocyte. I hope you all remember reticulocyte is stained with a very important staining process known as supravital staining. And the best example that comes under the supravital staining is NMB, that is new methylene blue. So this is one question that they ask you. The next one is, what is the composition of a reticulocyte? What is it made up of? What are these blue dots? So remember, reticulocyte is nothing but a reticulum of RNA. It's a reticulum of RNA, and for RNA, I basically need to do supravital staining. Many students ask me this question as well. Why supravital? Because RNA can only be stained in living state. So you need to do a supravital stain. The normal count is going to be 0.5 to 2%, which you are also asked in your exams. The next happens to be a set of needles. The chota wala needle has the chota wala name and the long one has the longer name. So remember, or the tubes, I would say, not needles. The tubes are going to be the Vintrobe. So chota wala tube is going to have the chota name. That is, the smaller tube is Vintrobe's tube. I call it a tube. Why do I call it a tube? Because it's open on one side and it's closed on the other. Whereas the other one is open on both the sides. And that is why I don't call it a tube, I call it a pipette. And that is known as the Westergren pipette. Because it's a longer pipette, I have a longer name for it. What are their uses? Remember, Vintrobe can be used for measuring both PCV as well as ESR. Westergren is only used for the measurement of ESR. So, how much is the RBC falling down? Erythrocyte sedimentation only for that, whereas Vintrobe is a very useful tube. If you count, I'll show you another Vintrobe tube. If you count from bottom, you can count the packed cell volume. So, if you see there's a bottom 0, 1, 2, 3, 4. So, if you start counting from the bottom, you can count the packed cell volume. Whereas, you will also see 1, 0, 1, 2, 3 from the other end. So, if you start counting from the top, you can count the erythrocyte sedimentation rate. So, you can do 2-in-1 use of this tube that you have, although it's a chota name, but it's very useful, and that is the Vintrobes, which can be used for PCV as well as the ESR estimation. Let's move on to the next. If I give you a question, if I give you a test right now, what is this? Is this a Vintrobe tube or is it a Westergren pipette? You will say it's open here, both ends are open and it's very, very long. So this is long wala name, that is the Westergren pipette. Let's move on to the next question. A classical case of iron deficiency anemia. What are the nail changes that you see? You see these spoon-shaped nails. So spoon-shaped nails are referred to as koilonychia. Spooning of the nails is known as koilonychia. What kind of an anemia is it? I hope you all remember iron deficiency anemia is small cells. They are microcytic hypochromic cells. And what is very, very important amongst them is going to be the formation of these long cells. These long cells are referred to as the pencil cells, which they ask you in the paper. This is quite characteristic of iron deficiency anemia. So yes, microcytic hypochromic cells. I hope you all remember microcytic hypochromic anemia had a couple of things. Remember the mnemonic Sita or Sheetal? Yes, so we've done iron deficiency anemia. What else was in it? We also have thalassemia. anemia of chronic disease, lead poisoning, and the last one is going to be sideroblastic anemia. That is the picture that I'm going to show you now. Iron deficiency ka to dekh liya. We are going to see sideroblastic anemia because sideroblastic tells me that there's sidro, there is iron overload, there is excess of iron that is going to be present. Now, whenever there is excess of iron, what will you see on a peripheral smear and what will you see on a bone marrow? So, on a peripheral smear, you see bodies called Pappenheimer bodies. They are made up of what? Of course, I'm saying iron excess. So, Pappenheimer bodies are multiple. You can see many dots. How will I confirm it is iron? Come on, this question you've been answering since ages. What is the stain for iron? You have the pearls or the Prussian blue staining. We have the pearls or the Prussian blue stain for iron, which is all-time favorite. So whenever I have Pappenheimer bodies, think of iron, think of sideroblastic anemia. This is what you see on a peripheral smear. What will you see on a bone marrow? I will see the presence of ringed sideroblasts. You're gonna see the iron is making a ring. Can you see those blue color dots? Why are they blue? I've used a pearls Prussian blue stain, and I can see the blue color dots which are present. That is gonna make it a ringed sideroblast. Everyone's clear with sideroblastic anemia? Let's move on to the next one. Can you answer this? Knuckle hyperpigmentation. I'm seeing hyperpigmentation of the interphalangeal joints. I will also see an element of hyperpigmentation on the knuckles. So when you see this kind of hyperpigmentation pattern, you have to think of B12 deficiency anemia. Matlab you are thinking of megaloblastic anemia. So what are the changes that you see in megaloblastic anemia? What kind of an anemia is it? Macrocytic. So let's see the pictures. The cells are going to become big. So here you've got normal cells. For comparison, I've got you normal RBCs, and here you can see the RBCs are becoming very big. That is going to be a macrocyte. Not only big, they are also becoming oval. If they are becoming oval, I call them macro-ovalocyte. So remember, macrocyte, macro-ovalocyte. Then what are these single dots that you're getting? I always used to tell you that जो single वाला dot होता है, that is Hobble Jolly body, and I give you a mnemonic also that during your exams you have to be single so that you can concentrate. So happy and jolly to be single is how you learn it. So these are single bodies. What are they made up of? They are made up of DNA remnants. And which anemia am I talking about, guys? They are seen in number 1 megaloblastic anemia, but other than megaloblastic anemia, please note, they are also seen in a post-splenectomy case. If you have a patient who's undergone a splenectomy, you will see the Hobble Jolly bodies. The next one is very simple. You see this beautiful figure of 8, and that has to be Cabot ring. Figure of 8 appearance, Cabot ring. What is it made up of? It is an arginine rich. They ask you which amino acid. It is arginine rich, and it's nothing but a mitotic spindle. So arginine rich mitotic spindle is gonna be the Cabot ring. Let me ask you a question. What all findings are you seeing inside this red blood cell? I see one dot, but I only see one dot. So happy and jolly to be single. This must be the Hobble Jolly body. And I see a ring. It's not necessary that hamesha figure of 8 banega. Ring can be of any size and shape, na? So this must be the Cabot ring. So in the same RBC, I'm seeing the Hobble Jolly body and the Cabot ring. This must be a case of megaloblastic anemia. Megaloblastic anemia is not over. Not only do you see these macrocytes, macrovalocytes, Hobble Jolly body, Cabot ring, you also see something in the red blood cells known as basophilic stippling, that dot thing that you're seeing. Basophilic stippling can be seen in megaloblastic anemia as you have over here. It can also be seen in cases of thalassemia. Finally, what is the feature that you see in the end? You see this is a 1, 2, 3, 4, 5, 6, 7 lobes in the neutrophil. Hypersegmented neutrophil is also a feature of megaloblastic. What is the criteria for hypersegmented neutrophil? Either you should have 5-5, matlab 5% of the neutrophils should show you 5 lobes, or even if one neutrophil shows you 6 or more than 6 lobes. So यहाँ कितने थे? यहाँ there were 7. Even if one neutrophil shows you 6 or more than 6 lobes, you call it a hypersegmented neutrophil. But if you're seeing 5%, 5, या तो 5% neutrophils with 5 lobes, or even one with 6 or more, you know it's a case of hypersegmentation and megaloblastic anemia. Moving on to the next picture. What is this? Where you see the cells which are totally smaller, they are totally round firstly. Spherocytes, but I like to call them microspherocytes because they have some very characteristic thing. Compare them with a normal RBC and their size is going to be smaller. So they are smaller in size. I like to call them microspherocytes. What is the most common cause of spherocytes, guys? Please don't say hereditary spherocytosis. Hereditary spherocytosis I'm keeping at the end. The most common cause is autoimmune hemolymph hemolytic anemia, then you have two more causes, that is G6PD deficiency and HS. So remember, spherocytes are not seen only. HS sounds like that, but it's not the common cause. This is a very important question. The most common cause is autoimmune hemolytic anemia. But I know your favorite cause is hereditary spherocytosis. So now I've got you the collage of hereditary spherocytosis. If you see these spherical cells, and if you're thinking hereditary spherocytosis, what are the two tests that you will be doing? एक तो screening वाला test करते हैं. This is known as the osmotic fragility testing. I hope you all remember that H for hereditary spherocytosis, H for high osmotic fragility. Cells are very, very weak. Cells are highly fragile. They break very easy. So the graph will shift to the right. You see a right shift that has happened in hereditary spherocytosis for osmotic fragility test. Remember, H for HS, H for high osmotic fragility. But that is a screening test. How am I going to do the confirmation of this? For the confirmation, I've got a flow cytometry in front of you. And that confirmation is done by a dye called EMA, eosin 5 malamide. It is done by a dye called eosin 5 malamide testing, and this is going to tell me that, okay, look at this. This person over here is totally normal. Eosin 5 malamide kya hai? Eosin 5 malamide is a dye. So if I see normal cells are getting say 10 ka intensity ka dye. But if I'm seeing cells which have hereditary spherocytosis, they are getting less intensity dye. That is eosin 5 malamide testing. So that is done by a technique called flow cytometry. So remember, osmotic fragility is screening and confirmation is by EMA method, that is hereditary spherocytosis. Let's pick up another shape related thing. If you see these kind of mushroom cells, what are these mushroom cells? As if something is pinching the cell out. Red blood cell is being pinched out. That is the pincer cell, and that is going to be a band 3 defect that you notice. This is important for the INI CET exam. Moving on to another shape related change. What is the difference between acanthocyte and echinocyte? Acantho word means spiky spur. So this is an acanthocyte where I'm seeing spiky spur, and A for A, it is seen in a case of A beta lipoproteinemia. That is very important. Whereas when I'm seeing cells which are totally blurred, ऐसा बिल्कुल zigzag blur हो रहा है. This zigzag blur वाला cell is going to be known as a Burr cell or an echinocyte. देखो, the way you write E is the same way you write B. तो echinocyte is Burr cell and acanthocyte is spur cell. ठीक है, acantho, spur, spike, same thing. तो वो spike वाला cell है. Whereas Burr is blurred, all around it is zigzag. Where do you see the Burr cell? So Burr cell is seen in B for Burns, it is seen in U for uremia, and it is seen in E for EDTA changes. These are the causes where you see the presence of echinocytes. And where do you see acanthocyte? A for A, that is seen in a case of A beta lipoproteinemia. Moving on to the next, the enzyme deficiency, G6PD deficiency. Whenever someone is having G6PD deficiency, the two main findings that you have to know is, number one, a cell in front of you. It's looking as if someone bit it. It's known as a bite cell or a degmacyte. There are lots of Ds. Don't get confused. If I say bite cell, kya hota hai? Degmacyte, drepanocyte, dacrocyte. Remember, dog bite. So degmacyte is going to be a bite cell. And then what is the bodies that you notice? We see the very famous Heinz bodies. Now the problem with, you've seen so many bodies, like you saw Pappenheimer bodies made of iron, you saw Hobble-Jolly bodies in megaloblastic. Now I'm showing you the Heinz body, and the difference is that Heinz body is made up of denatured hemoglobin, kharab wala hemoglobin. Why is hemoglobin kharab? Because G6PD was not there, so the hemoglobin got spoiled. Normal hemoglobin would have been stained like this with Romanovsky stain, but spoiled hemoglobin will not be stained with Romanovsky. They ask you which is the body which is not going to be stained on Romanovsky stain, that is Heinz body. So what stain have I used over here? This is the famous crystal violet stain. Very important PYQ. Heinz body is made up of bad hemoglobin. Denatured hemoglobin will not take up the normal stain, it will take up crystal violet stain. Okay, so Heinz body dikhega, bite cell dikhega. Sometimes the bite cell starts looking like a blister. Bite ka hi variation hai, it starts looking like a blister. So some people also say that blister cells can be seen in G6PD deficiency. Let's move on to the next disease. Tell me what is the genetics in this. Paroxysmal nocturnal hemoglobinuria. What are the CD markers that have gone missing in this condition? So it is going to be CD55 and CD59. I hope you remember, chota wala number is known as DAF and bigger number is known as MERL, right? So DAF and MERL are the other names of CD55 and CD59. There is a screening test that has been put up in front of you for paroxysmal nocturnal hemoglobinuria. Patient will come to you with nighttime passing hemoglobin in the urine. Screening test is gel card. Do you remember how do you do the analysis of a gel card? If you get a line at the top, it is considered positive. If you get a line niche, bottom, that is considered negative. So that was my mnemonic for it. What did I say? If I get a line at the top, it is going to be positive result. If I get a line niche, that is going to be negative result. So top पे line आया, यहाँ पे top पे line है, top पे line है. This means DAF is also there, MERL is also there. All of us have DAF and all of us have MERL. We are normal people. So this patient that has been mentioned over here is normal. Whereas यहाँ पर there is no line at the top. I don't see any line at the top. I see all the lines are at the bottom. नीचे 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 मतलब negative. If CD55 and CD59 are gonna be negative, this means it's a case of PNH. So simple. Top पे line आया तो positive, नीचे line आया तो negative, and when these are not there, patient has PNH. However, is that the confirmatory test? No, that was a screening test. Tell me, what is the confirmatory test? It is going to be flow cytometry. We are finally going to measure it with the help of flow cytometry and find out that CD55 and 59 is present or not. After this, I'm going to show you an image which is important, really important for INI CET exam. This is a very rare kind of a hemoglobin disorder known as hemoglobin C disease. Hemoglobin C disease shows you these kind of crystals. These are known as hemoglobin C crystals. Again, something which is important only for the INI CET exam, because hemoglobin C is a disorder at which the beta 6 position mein glutamate will change to lysine. Glutamate changes to lysine, that is hemoglobin C disease. But what is important for every exam is going to be sickle cell. Sickle cell anemia. Come on, tell me what is the genetics of sickle cell anemia. At beta 6 position, glutamate will go, and who is welcome? Valine is welcome. Glutamate is going to go away and valine is going to be welcome. So I don't have to give you any mnemonic. You can see that यहाँ पे कितना अच्छा beautiful sickle cells are seen. Sickle cells are also known as drepanocytes. Will you get confused? Sickle cells are degmacyte or drepanocyte? So you'll say degma was bite, dog bite. So the bite cell was degmacyte, sickle cell is drepanocyte, as you can see over here. Is there any test where I can get more and more sickle cells? More and more sickle cells can be identified? Yes, that is the sickling test. What is the sickling test, guys? Please note that in sickling test we use the famous chemical. That is the only question that you get. What is the chemical used in the sickling test? Mug it up with me. 2% sodium metabisulfite or diethionite. Please, 3 times we will repeat it because this is definitely going to be a question. What is the chemical used for the sickling test? I want to make all the cells sickled. So either you can use 2% sodium metabisulfite or diethionite. Metabisulfite, diethionite. Metabisulfite, diethionite. So that you know that ma'am said it 3 times, and that is how important it is. And I will definitely get a question on the chemical used for the sickling test. But this is all screening. Come to the confirmation. What do you use for confirmation of the hemoglobin disorders? We use HB electrophoresis. Guys, what do we do in HB electrophoresis? Every electrophoresis will have a positive end, which is the anode, and it will have a negative end, which is going to be the cathode. And we learn the mnemonic, which is going to be HAFSA. What is HAFSA mnemonic? So hemoglobins mein, when I look at the hemoglobins, the first hemoglobin jo anode ke paas kaun sa aata hai? Anode ke paas we have hemoglobin A. After that, the next one we have is hemoglobin F. After that, the next one we have is S, and S ke sath D also tends to overlap. And then finally we have another A, so that must be A2. The second A is A2. So remember, A, F, S, A2. These are the hemoglobins from anode to cathode, but overlaps are there. S is going to overlap with D, and A2 is going to overlap with hemoglobin C, E and O. Repeating, S is going to overlap with D, and A2 is going to overlap with hemoglobin C, hemoglobin E and hemoglobin O. So how do I differentiate? Especially I want all of you to know the differentiation between S and D. Why? Because hemoglobin S is sickle cell anemia and hemoglobin D is a condition known as HBD Punjab, because it is very common in the Punjab belt. How will you differentiate? Let me tell you. This electrophoresis that you were doing this at a pH of 8.4. This was done at pH of 8.4. That is why you were getting SD, SD ek saath. If you want to differentiate between them, you will now do it at pH of 6.8, means a little acidic, and then you will be able to differentiate between the two. Please note, the normal electrophoresis is done at an alkaline pH. That is why SD are coming together. You make it acidic and toxic banaoge, every couple is going to separate out. So if you make it acidic and toxic, that is acidic 6.8, the SD couple is going to split out. So let me ask you a question. If I say, this is your patient, these three people, can you give me their diagnosis? You will say, all three of them are showing me hemoglobin A, adult hemoglobin, ye तीनों normal log hai, ma'am. These are all three normal people. Okay, then what is this person? All his hemoglobin is coming in the SD range. Either he is sickle cell anemia or he is hemoglobin D Punjab. Please make it acidic. Please make it acidic and toxic. Then only I'll find out whether it is sickle cell or whether it is Punjab. Next, what is this person? This person has two bands. A little bit of adult and a little bit of sickle. This means this is a case of a sickle cell trait. He has both hemoglobins, he is sickle cell trait. That is how we do the diagnosis using HB electrophoresis. But is that the gold standard? No. The gold standard for all hemoglobinopathies is gonna be HPLC. I just want to tell you how an HPLC graph looks like. I don't want you to learn the timings and everything, but just learn that if this kind of a graph is written, then you should know, okay, that is an HPLC graph and that is the hemoglobin ka gold standard for all the hemoglobinopathies. So now when I'm talking about sickle cell and hemoglobinopathies, why don't I talk about another very important one, and that is going to be a case of thalassemia. So under thalassemia, what do you see? Firstly, the face and the head abnormality. You will see that they will have very prominent maxilla and frontal, that is known as the chipmunk faces. They will have something on the scalp, that is crew cut, as if boys make that hair on end, that spiky hair wala hairstyle. So that crew cut or hair on end appearance with chipmunk faces are these findings. Let me tell you, crew cut appearance is not just for thalassemia, it is also for sickle cell anemia. And what does thalassemia show you? T for T. Thalassemia is going to show you lots and lots of target cells. These are the target cells, the cells with a dot in the center. Target cells are also known as codocytes. They are also known as codocytes. Tell me one thing, these are features more of thalassemia major or Cooley's anemia. Is there any screening test that we do for thalassemia? Yes, I'm going to write the mnemonic thalassemia like this. Everyone, from today onwards, you will write thalassemia like this, because first I'll tell you there is a test called Nestroff. Full form dekho kya hai. Naked eye means you don't need any microscope, you're doing this test with your eyes. Single tube, you're just using a single test tube in front of you and testing ROF, red cell osmotic fragility. Let me tell you that thalassemia, T for T, thalassemia cells are very, very tough. Means, will they break? No. You all have to be thalassemia cells. You have to be very tough in this situation. Anyone puts you in any situation, you're not going to break. So remember, thalassemia cells are very, very tough. Now, when these thalassemia cells are very tough, if I put that cell in a hypotonic saline, if I put this cell in a hypotonic saline, normal cells will to break off. Normal cells will say, we cannot tolerate hypotonic saline. Normal cells are going to break off. However, thalassemia cells are very, very tough. They will not break off. So, ye dekho. Normal cells will say that, okay, for example, if these were the cells, okay, these were the red blood cells. Normal cells said, I can't take so much of pressure. I am to breaking off. So that tube becomes transparent, you can see through and through. But thalassemia cells say that no, we are gonna be standing here, we are tough people, we are not going anywhere. So tell me one thing, in which of these test tubes will you be able to see the background lines? You'll say, jo ma'am normal wale the na, they broke off, so I could see the background line. Thalassemia cells were very, very tough, I could not see the background lines. So please remember, in thalassemia you will learn AL for absent lines. On your Nestroff test, you will get absent lines. You will not be able to. So in your exam, when you quickly have to make the diagnosis, okay, I'm not seeing the line through this must be thalassemia. I'm seeing the line through this, means this must be a normal case. Simple with everyone. So remember that if the lines are absent, means you have thalassemia blood. But there is one more thing which I want to tell you, which is theoretical. Why did I also learn it as thalassemia? Because I hope you remember, guys, there is an index called the Menzer index. Can you revise with me? What is Menzer index? M and R lena tha. It is MCV upon RBC. And we had studied, is it 13 for 13 and less for less? So thalassemia mein Menzer index is going to be less than 13. What's your mnemonic? You'll take the first and the last letter of Menzer. It is going to be MCV upon RBC. And thalassemia mein it is less than 13. Whereas what is the case of iron deficiency anemia? The Menzer index is more than 13. That is why I've given you this mnemonic. That thalassemia mein it is less than 13. Simple. So thalassemia mein absent lines and Menzer index is less than 13. The name is your mnemonic. Let's go on to alpha thalassemia. What is alpha thalassemia? This is going to be a case of he is a boy, plays golf at 3 a.m. What is this? He means, I'm talking about HbH disease. Boy means that this is going to be something which is going to form. What is HbH if someone asks you? They are beta 4 tetramers. Why did beta tetramers form? Matlab alpha chala gaya. He's playing golf at 3 a.m. Why 3 a.m.? Because 3 alpha minus. 3 alpha genes are missing. 3 alpha genes are minus. They are missing or deleted. And why is he playing golf? Because what I see over here are the golf ball inclusions. Remember, this stain that has been used over here is the new methylene blue. So repeating once again, guys, that he, that is HbH, who is a boy, that is beta 4 tetramers, is playing golf, that is golf ball inclusions at 3 a.m. in the morning. Breakup ho gaya. So 3 a.m. in the morning, he's keeping himself distracted by playing golf. Why breakup ho gaya? Because 3 alpha is missing. His partner is missing. 3 alpha genes have gone missing. He, who is a boy, is playing golf at 3 a.m. Golf ball inclusions. Question comes, ye photo diya hota hai and they ask you how many genes are missing. 1 gene, 2 gene, 3 or 4. So now you know 3 a.m. 3 genes are missing. Let's move on to the next anemia, that is the cold agglutinin disease. And we all remember from our theory a mnemonic Mike, which meant that in cold agglutinin disease, which means at 4 degrees centigrade, it is going to be which antibody working? It is IgM antibody against which antigen of the blood? Against I antigen of the red blood cell. So, IgM antibody against the I antigen in cold temperatures is known as cold agglutinin disease, and agglutinin definitely tells me that all the cells are agglutinated over here. They've made clumps or agglutinated, right? The same thing if I would have asked you about warm autoimmune hemolytic anemia. So, warm ke liye kaun sa antibody hota? It would have been garam antibody, IgG antibody, and warm means 37 degrees centigrade. Na warm, that is what you have in warm AIHA. Against which antigen of the red blood cell? Against the P antigen. That is why I gave you a mnemonic Mike. Cold ke liye it is IgM against I antigen. The next one that you have is when the RBCs are going to break off and they've broken into such weird shapes. Fragmented RBCs. Over here it's looking like a helmet and a hat and all weird shapes. So that's known as a schistocyte. When do you see broken cells? Either a case of macroangiopathic hemolytic anemia. Guys, what was the example of macroangiopathic hemolytic anemia? Whenever someone has put prosthetic heart valves. And microangiopathic hemolytic anemia ke liye you have a trio, that is HUS, TTP and DIC. The bottom line in all of them is all of them have some rock form. Ek rock hai, theek hai? There's a rock and these are like my tiny little red blood cells. If there's a rock and my tiny little red blood cells will go and attack, my red blood cells will break. Rock to wahi rahega, my red blood cells will go and break. So for example, if there's a prosthetic heart valve, my red blood cells will go, they hit the rock and they broke. In HUS, TTP and DIC, what happens is that there are so many clots that are present in the blood vessel that these clots are like a rock. My red blood cells will go hit and break. So that hit and break is going to result in fragmented red blood cells known as schistocytes. Coming to the next, this is something I've got from virology. There is a virus which shows you in the red blood cells these dog ear protrusions. So what cells are affected? RBC precursors are affected. And RBC, for example, if this is an RBC precursor, I am talking about parvovirus B19 infection. So let me tell you what is important about this parvovirus B19 infection. So remember, firstly, it is going to show you what? It is going to go and attack red blood cell to samajh aa gaya, but which antigen of the red blood cell that it attacks? P for P. It attaches the P antigen of the red blood cell. Second, it's going to show you P for projections, and that is the picture shown in front of you. It shows you these dog ear protrusions or projections. Dog ear protrusions or projections are noted over here. That is parvovirus B19, right? So parvovirus, P for which antigen of red blood cell? P antigen, and which projections? Dog ear. And what does it cause? The last P, you've forgotten the disease. pure red cell aplasia. It causes PRCA, pure red cell aplasia. That is why I wanted to make the parvovirus ka P's very, very clear in front of you. Let's move on to the next one. We are done with all the RBC things. We can go on and talk about the WBC things now. And under WBC, what do we have? The first one is going to be all the myelopoiesis. Myelopoiesis matlab how from a myeloblast everything is forming. So jaldi se should we revise? Why did I call the first cell of a myeloblast? What do I see over here? I see the very, very famous OR rods. Yes, if I see the presence of OR rods, I know that I'm dealing with only one cell possible, and that is a myeloblast. After a myeloblast comes the biggest member. Big matlab pro hai, family mein pro hai. Why? Because he's the biggest in size, and that pro is going to be known as a promyelocyte. Then you will cut out the pro. Cut the pro. What are you left with? You're left with myelocyte. Ab myelocyte ka kya hai? Myelocyte is very, very blessed. What are all of you working for today? You're listening to this snapshot video. You want to clear your MD exam. Myelocyte ke paas MD hai. Myelocyte has MD, means it has a D-shaped nucleus. Myelocyte is identified by the presence of a D-shaped nucleus. Okay, then who see? You don't have MD, so you want MD. When myelocyte got MD, myelocyte said, I want super speciality. I want some extra degree. So now it has become myelocyte, so it has become metamyelocyte. It has become a meta-human. It wants to basically become super specialist. So metamyelocyte, M and M, the way you write na, M and M, jaise M and M dikhte ho. The nucleus is also going to become a little indented like an M. So simple, myelocyte ka nucleus is MD degree D shape, and metamyelocyte ka nucleus is like M, little indented. Finally, it becomes highly indented. It is looking like a band, and that is known as a band or a stab form. And from there, finally, you have the different cells. That is either NBE, your favorite organization for exams, neutrophil, basophil, eosinophil. So basically, in this pathway, which are the three WBCs formed? Neutrophil, basophil, and eosinophil. So on that note, before I move forward and I show you all these cells, I want to tell you the difference between a myeloblast and a lymphoblast. Are you ready for that? Myeloblast and lymphoblast ka difference to sabse easy hai. If I see the presence of an OR rod, I know I'm dealing with a myeloblast. It's very, very obvious. And when I don't see the presence of OR rods, I know I'm dealing with a lymphoblast. But they will ask you the stains. So myeloblast ka stain kya hai, guys? For myeloblast, we have the famous myeloperoxidase, MPO, SBB, CAE. That is how I had learned it. Three letters. MPO, myeloperoxidase, SBB, that is Sudan black B, and CAE was chloroacetate esterase. These are the three stains that we use for myeloblast. Now let's come to lymphoblast. Lymphoblast ka stain is very essential. Lymphoblast is going to show you two stains, that is PAS positivity and acid phosphatase, jisme I need to know an image of PAS positivity. P for PAS, P for pink. It's gonna show you pink color blocks. Lymphoblast shows you pink color blocks. That is known as block या dot blot या block positivity. कुछ block word लिखा होगा. So remember, lymphoblast is gonna have some block word written with PAS. That is very, very important. Now let's identify. You've done all the blast wala, myeloblast ho gaya, uska lymphoblast ho gaya. You've done the differences between the two. Come to the mature cells. The mature cells are the famous never let monkeys eat bananas. What is that in the descending order? Never. So neutrophil, lymphocyte, monocyte, eosinophil, basophil. That is never let monkeys eat bananas. How do you identify them? Jaldi se let us do them. Neutrophils are identified by the lobes. You can see these lobes. 3 to 5 lobes are going to be there. Okay, lymphocyte is simple looking round cell, nothing to worry. Monocyte is identified by its kidney. You can see the kidney shaped nucleus. The monocyte is identified by the reniform nucleus. Eosinophil is the only cell that I have which is, see, this cell is very, very orange and this cell is very, very blue-black. So simple, those cells hain. One cell is going to be very, very orange, and that orange cell also has a spectacle wala nucleus, that is an eosinophil. Orange cell with spectacles, that is eosinophil, whereas BBB, blue-black granules wala jo cell hoga, that is going to be a basophil. So I understand that basophil to least hai. Blood mein hardly one basophil you will find. So ma'am, when it is so difficult to find a basophil, why don't I have a stain? That's the next question that came in NEET and FMG, guys. What is the special stain that you have not only for basophil but also for mast cells, and that is toluidine blue. So please remember, basophil looks like what? It shows you blue-black granules, and what is the stain? That is also going to be a little blue. That is a toluidine blue stain. Okay, for basophil as well as for mast cells. Done with this, let's move forward and ask you something, some variation. This is also a neutrophil. But yes, why did I say neutrophil? 1, 2, 3, 4, 5 lobes hai, neutrophil. But this neutrophil is showing you these bodies. What are these? These are the Dole bodies. Now let me tell you that Dole bodies are gonna be DLO, that is dilated, and ELO, last alphabet, endoplasmic reticulum. Dole bodies are dilated endoplasmic reticulum, and they are going to be seen in severe infection. That is a case of sepsis. It is very important. Ho gaya Dole bodies, right? These big bodies that you're seeing over here. Let's move forward. Let's go to the leukemias. The one that I have in front of me is ALL. Yes, all of you look very pretty in the mirror. So what is it? ALL can show you what kind of blasts? Blasts which are going to look like hand mirror, like hand mirror shape ka blast hoga. So remember, all of you are looking very pretty. That's why I made a tiny little heart over here. All of you are looking very pretty in the mirror. That is going to be hand mirror blasts. But as per the FAB classification, ALL is of 3 types: L1, L2 and L3. And the question that they get, ठीक है, L1 में you'll say, ma'am, सबका same छोटा same size. All of them are of the same size. So these are what? Homogeneous blasts. 1 L1, one type of blasts. As soon as I say L2, 2 types of blasts, heterogeneous blasts will be noted, means some of them are chota, some of them are big. So L1 mein one size of blasts, L2 mein 2 sizes of blasts, but L3 is what is the most important. Can you see these white holes? Those white holes are referred to as the vacuolations. So L3 is the one that has vacuolations because of what? Because it contains fat. It is oil red O positive. This is a very important previous year question that you have to know. Which ALL is gonna have vacuolations? L3. Moving on, this was all about ALL. What will you see in AML? Of course, AML matlab myeloid, myeloblast matlab or rods. But here I am showing you a very important type called AML M3, NEET PG 2023 question. Which AML has the maximum or rods? The maximum OR rods are going to be seen in AML M3, and you can see these OR rods are not just there, they are crisscrossing. So please remember, these OR rods will be seen in a crisscross manner. What are these cells? This crisscross wala known as, they are referred to as the faggot cells. These are referred to as faggot cells. So can you tell me some questions? AML M3, 3 ka multiple 15, translocation 15, 17, it is going to be a PML RARA fusion. PML RARA fusion. If you go into PML RARA matlab retinoic acid, ये कुछ retinoic acid का problem हो रहा है. So the treatment will be all trans retinoic acid and arsenic trioxide. All trans retinoic acid and arsenic trioxide. This is the only leukemia, label it out, the only leukemia to be associated with DIC. So these two, faggot and DIC, so as it is, ratlo, put it in your system, absorb it in within you. Remember AML M3, 3 ka multiple 15, 15, 17, retinoic acid ka problem hua, so treatment has to be all trans retinoic acid. This shows you some deadly fatal faggot cells, and fatal disease matlab DIC. Faggot bhi deadly naam hai, DIC bhi deadly naam hai, so AML M3 mein dikhta hai. Acute leukemia is done. Let's move on to chronic leukemias. Chronic lymphocytic leukemia. What did I say? Chronic lymphocytic leukemia, you are only seeing one kind of cell, that is lymphocyte. Sare cells same dikh rahe hain, like someone is wearing a uniform. That is why you call it a convent school girl appearance. All of them are lymphocytes, but some of the lymphocytes are broken. What are those broken lymphocytes known as? Smudge cells. This is not any specific finding, very important, but non-specific finding. You can see it in any other disease. But when you get this in the exam, the first thing you think of is CLL. But what is it? Why are cells breaking off like this, ma'am? The cells are breaking off like this because they have lost a very important molecule. There is loss of vimentin. This theory is known as the cytoskeletal theory. This theory is called as cytoskeletal theory. Their backbone has gone. That is why they are breaking. So this is non-specific. So this is not criteria. What is the criteria for the diagnosis of CLL? Ma'am, only think of lymphocytes. Absolute lymphocyte count has to be more than 5,000. Matlab if you're doing a peripheral blood analysis, simple blood sample liya, to peripheral blood mein more than 5,000. Bone marrow mein lymphocytes have to be more than 30%. And CD5 and CD23, and now there's a new marker that is CD200. All of them have to be positive. Basically, we had learned CLL mein sab kuch positive. 5 also positive, 23 also positive, 200 also positive. Very important point. CLL done. But now I'm going to go on to the next one. We all know what am I talking about. Firstly, you know this from genetics chapter. What technique is it? It's the fish technique. And I can see they've written, so nice of them, they've written red color for ABL, green color for BCR. Anyway, when they write BCR ABL, I know they're talking about translocation 922. That is BCR ABL fusion known as Philadelphia chromosome. And can I see that? See, jab tak red and green alag alag tha, BCR and ABL alag alag tha, okay, we are normal. But over here I'm seeing BCR and ABL have fused. The red and the green have basically fused, and when red and green fuse, you get a yellow color. So that is the fusion that I'm encountering over here. So this is a case of CML. So how does a CML bone marrow look like? It's a full garden party. Garden party means everyone is different, like college girls, no uniform. Dekho, CLL mein there was a uniform. There were only lymphocytes. So everyone was looking the same, convent school girl. Here you don't have any uniform. Everyone is dressed differently, like a garden party. Let's try and identify. This is a neutrophil, this also is a neutrophil, ye kidney wala hai, this must be monocyte, this is that D-shaped nucleus, this must be that myelocyte, MD, D-shaped nucleus, this is the biggest cell, this must be the pro of the series, promyelocyte. Orange wala kuch toota phoota cell, orange must be eosinophil. So basically full garden party happening over here. That is a case of CML. Is there any stain for CML which is very, very important that you all have to know? I hope you all know there is a score that we study called the neutrophil alkaline phosphatase or the leukocyte. Ya to LAP bol lo ya NAP bol lo, whatever you want to call it. Leukocyte alkaline phosphatase or neutrophil alkaline phosphatase. And the normal score is going to lie between 40 to 100. So remember, in CML and in PNH, this is less than 40. Normal score was 40 to 100. So remember, CML sounds like small, na? That is why I can say that in CML, the LAP score is going to be low because CML sounds like small. So the LAP score is going to be low. Whereas when is the LAP score going to be more? Common sense. LAP score matlab NAP score, neutrophils. Wherever the neutrophil count will go up, the LAP score will also go up. So what are the conditions? Lakes and ponds. L stands for leukemoid reaction. In leukemoid reaction, there is increase in neutrophil. We all know pregnancy mein there is increase in neutrophils. We know OCP usage is increase in neutrophils. Neutrophilia is of course an increase in neutrophils. And yes, there is also a chromosomal abnormality called Down syndrome. So remember, in lakes and ponds, whenever the neutrophil count will go up, obviously the NAP score will also go up. And when does the NAP score go low? When in cases of CML and PNH. Simple normal NAP score 40 to 100. So all your leukemias are done. What do we move on to next? We are going to go on to the lymphomas, and you know which lymphoma have I written in front of you. I'm not going into the theory of it because I guess we've done all this theory in a rapid review. We are going to take care of all the images about it. So first I see the very, very famous, the Reed-Sternberg cell, the classical Reed-Sternberg cell, and you know this very famous owl eye appearance that we have. So can you help me with the markers? It is CD15, it is CD30 and PAX5. Out of them, if they give you this picture, which is the sensitive marker, CD30 is sensitive and PAX5 is going to be specific. That is the Reed-Sternberg cell, Owl-Eye-ka classical Reed-Sternberg. However, in the next picture, I see there's a white area around it. There's a lacuna around it. So where do you see lacunar RS cells? Guys, rhyming karo. Lacunar RS cell is seen in nodular sclerosis. Lacunar RS cells are seen in nodular sclerosis. The last one, the RS cell has started looking like a popcorn. Where do you see the popcorn RS cell? Can you see the popcorn over here? Where do you see popcorn RS cell? This is the non-classical NLPHL, nodular lymphocyte predominant Hodgkin's lymphoma, shows you the popcorn RS cells. And in fact, I hope you remember, this was the one that had the best prognosis. Iska bahut kuch alag tha. This was the one that had the best prognosis. This was the one that had nothing to do with all those markers that you are reading. It is no 15-30 wala scene. It is totally different. It is a set of 20, 45, EMA and BCL6. That is what you had studied in your theory. Ye sabse alag hai. Popcorn, tasty wala cell alag rakho. Keep your tasty food aside. This is the one which has the best prognosis because popcorn is so tasty. And this is the one which is not the usual wala markers. This is the one which is 20, 45, EMA, BCL6 positive. Let's move on to, this was all Hodgkin's lymphoma. Let's move on towards a non-Hodgkin's lymphoma, and that is Burkitt's lymphoma, associated with which virus? The very, very famous Epstein-Barr virus. What is the usual history that I get? Because Epstein-Barr virus is endemic to Africa. Epstein-Barr virus is endemic in Africa, so you will get an African child with jaw swelling. If the first line of your paper is this, African, 10-year-old African child with a jaw swelling, and this kid is a celebrity because he comes in every grand test and every exam paper. You know your case of Burkitt's. And what does Burkitt's show under the microscope? It shows you a lot of vacuolations. Vacuolations क्यों? Because fat है, मतलब oil red O positive. This is what it shows under aspirate. What will it show under biopsy? The famous starry sky appearance. So look at the background. The background is all in all very, very dark. Very, very dark background. So sky hai. That's the cancer. And then I see few shining stars. Chota chota stars. So they will ask you, what is the sky? The sky is the tumor. The cancer is the dark, dark sky. And the shiny stars are nothing but macrophages. So where is the fault? Stars or sky? We always read fault is in the stars in book hai na, but now we will say fault is not in the stars, fault is in the sky over here. Sky, that dark, dark sky in the background, that is the cancer, whereas these shiny little cells are nothing but innocent macrophages. Is there any special stain? Yes, Ki67, this is the only tumor where Ki67 is almost 100%. Very few tumors can have this. This is one of those. So remember, African child jaw swelling with fat, oil red evacuation, starry sky appearance, Epstein-Barr virus, and Ki67 100%. Coming to the next, this image is only important in case you're targeting INI CET exam. There is a lymphoma called mantle cell lymphoma. Mantle cell lymphoma में सब कुछ mental हो जाता है. That is how we had learned. Mental मतलब they asked you which is the cyclin positive. I cyclin D, E, A, B, C. कौन सा cyclin? So you said mantle. Mantle में सब कुछ mental मतलब dumb. Mantle, mental, dumb. It is cyclin D1 positive. And you know one more thing goes mental in this mantle cell lymphoma. GIT also goes mental in this mantle cell lymphoma. तो GIT में बहुत सारा polyps बन जाता है. GIT starts showing you a lot of polyps, but those polyps are not like जो Peutz Jeghers and वो वाला polyps. No, those polyps are lymphoma polyps. So I call it lymphomatoid polyposis. Polyps are there and they are lymphoma polyps. You can see these blue color lymphoma cells. These are all the lymphoma polyps. Which lymphoma? Mantle cell lymphoma. So remember, mantle cell lymphoma mein GIT also goes mental. And how do you differentiate these three? I want to quickly revise this with you. What is the differentiation between CLL, SLL, mantle cell lymphoma and marginal zone lymphoma? तो देखो CLL में we had done सब कुछ positive, 5, 23, 200 सब कुछ positive. Margin में ignore the margin. Margin को ignore करो, everything is negative. And mantle वाले में that 5-year-old boy has become mental. छोटा सा बच्चा has become mental, बाकी सब तो ठीक है. So 5 is positive and everything else is negative. Remember, CLL, SLL सब कुछ positive. Margin को ignore करो, सब कुछ negative. And mantle cell में 5-year-old has become mental, rest everything is negative. So when I said lymphomatoid polyposis, I can say that CD5 is positive, 23 and 200 are gonna be negative. Let's move on to the next one, and everyone's favorite. You see it once, you'll never forget it. This is the famous hairy cells that you're seeing. And as soon as you see hairy cells, you know that there is a very famous microscope that can help in identifying it, and that is the phase contrast microscope. Phase contrast. And we had studied that hairy cell leukemia is, remember, I'm not repeating the story, but you all know the story of that. I've done it in the RR also, and I've done it in the main videos also, the famous story of that viral social media obsessed boy who has obsession with gym and fried eggs, hai na? So what are you gonna see on a bone marrow biopsy? That is what I wanted to ask you. Bone marrow biopsy shows you the famous fried egg appearance, hairy cell leukemia ka bone marrow, repeating bone marrow biopsy. So you can see there will be a white area around every cell. Every cell will have a white area around it, just like a fried egg. Similarly, look over here also, every area has a white area around it. Every cell has a white area. Fried egg appearance on a bone marrow biopsy. Why am I emphasizing? Because bone marrow aspirate pe kuch nahi aata. Bone marrow aspirate is a dry tap. Bone marrow biopsy shows you fried egg appearance. So what is the marker? Guys, the best marker that you have is gonna be annexin A1, not annexin 5. देखो hairy cell में A1 आता है. Hairy cell has A1. So you will be selecting annexin A1 over here. Annexin 5 कहाँ था? Annexin penta, annexin 5, annexin penta. A apoptosis. Don't get confused. This is annexin A1 because hairy cell has AI in it. Moving on, what are the CD markers? 11C, 25 and 103. And I give you a way of learning also. This is a hairy cell. So side, candid view wala photo tha. Candid view mein kya hoga? Your nose will look like 1, your face will look round and your ears will look like this. Let's repeat. Candid agar dekho, photo click karo, so your nose will look flat, your face will look round and the ears are going to look like a 3. So CD 103 pe question bahut aata hai. Finally, they will ask you, hairy cell leukemia ho gaya, all these were BB lymphomas. Now they also ask you, is there any cutaneous T cell lymphoma that you want to tell us? Cutaneous means there is involvement of the skin. Cutaneous T-NHL, yes. There is a very famous one called mycosis fungoides, and even in your systemic path chapter, I told you, if mycosis fungoides is asked, you are going to go ahead and give me the answer of a microabscess with P. So PM banana hai na? Remember that mnemonic? So these collections that you're seeing of cells over here in the skin, this is a skin biopsy. This collection is known as the Potrier's microabscess. Also, if this mycosis fungoides, which was in the skin, decides that I want to now go into the blood, I want to go and spill over into the blood. So what do you call it? You call them tongue twister. You call them Sézary cerebriform cells. So can you see the cells have sulci gyri jaisa indentation? So remember, till the time this lymphoma was in the skin, I called it mycosis fungoides. It was showing me Potrier's microabscess. As soon as it decided to spill into the blood, I said, oh, blood mate is the cerebriform Sézary cells. Like I said, tongue twister. Cerebriform Sézary cells, and this is known as the Sézary syndrome. This is the first TNHL. What is the next TNHL that all of us have to know? It's the very, very famous anaplastic large cell lymphoma. Anaplastic large cell lymphoma shows you two very famous cells. The first one is self-explanatory. It is looking like a donut, and the second one is looking like a hallmark. Hallmark matlab aisa kidney shaped cell. So you will see lots and lots of kidney shaped hallmark cells. This is the only lymphoma that shows you these kidneys. So kidney and donut matlab kidney matlab hallmark. Hallmark and donut is what you see in anaplastic large cell lymphoma. So on that note, all your lymphomas are also sorted. Let's move on to the next set of disorders, which are going to be the plasma cell disorders. But before I start with plasma cells, I will have to tell you what a normal plasma cell looks like. So sabse pehle tell me, what is the location of the nucleus? The nucleus is always on one side. That is why it is known as the eccentric nucleus. Point number 1. Then when I saw the nucleus, it had lines inside it like a wheel. So I said it shows you cartwheel chromatin. And on the side of the nucleus, there is a white area. So I call that perinuclear halo. The reason for the perinuclear halo is a lot of Golgi apparatus that is present alongside it, right? So repeating, there is an eccentric nucleus with a perinuclear halo and a cartwheel chromatin. That is what makes it a plasma cell. On the other hand, plasma cell ka mimicker kaun hai? This is important only for INI-CET students. Plasma cell ka mimicker is osteoblast, because guys, plasma cell is also in the bone marrow and osteoblast is also in the bone only. But what's the similarity? Dekho, dono ka nucleus is on one side. Dekho, the nucleus is coming on one side, and if you look carefully, there is a whitish area also, but that whitish area is not chipka hua to the nucleus. If you saw in plasma cell, the white area was just around the nucleus like this, chipka hua to the nucleus, perinuclear halo. Whereas in an osteoblast, it is away from the nucleus. It is paranuclear. So look at this. The nucleus is over here and the halo is over here. The nucleus is over here, the halo is over here. Paranuclear halo is seen. That is what you call as osteoblast. Now, right now, I'm obviously concerned with plasma cell disorders. All of us know what is the tumor of the plasma cell known as. It is known as multiple myeloma. And what does it show very commonly? It shows lytic bony lesions. That is how the history is going to come. So how does it affect the bone? It affects the bone by forming lytic bony lesions. How does it affect the kidney? In the kidney, it results in the formation of myeloma kidney. Myeloma kidney matlab multiple myeloma means lots and lots of light chains, antibodies banengi, lots of light chains. Those light chains will form this kind of a cast in the kidney. This is known as a light chain cast. This is what you see. Again, something, this is only important for the INI-CET exam. This light chain cast ka photo along with this lytic bony lesion comes. Anyway, you will be able to correlate कि अच्छा lytic bony lesion, multiple myeloma, साथ में this light chain cast is noted. Now let's look at the blood findings. What will you see in multiple myeloma? So firstly, you actually see a problem in the red blood cells, and that is the very, very famous Roulet formation. You see the very famous Roulet formation. What is Roulet formation? The RBCs are going to look like this. They look like a stack of coins. So in multiple myeloma, this is what you'll see on a peripheral smear. You'll say, hang on ma'am, multiple myeloma is a tumor of plasma cell and you are showing me RBC findings, because did you forget, plasma cells are only seen in the bone marrow. Plasma cells are not seen in the peripheral smear. So tumor will be sitting in the bone marrow. When you look at the basic red blood cells, the red blood cells are not going to show you the plasma cells. Red blood cells यहाँ पर peripheral smear will show you only red blood cell वाला finding. यहाँ plasma cell नहीं होगा. Where is the plasma cell sitting? In the bone marrow. So how do I guess a patient? I get a patient with lytic bony lesions. A simple blood test is showing me Roulet formation. I'll say, oh, Roulet formation and lytic bony lesions. Does he have multiple myeloma? Let me open his bone marrow. Let me see his bone marrow. So when I saw the bone marrow biopsy, firstly, when I saw the bone marrow biopsy, I saw sheets of plasma cells. What are these sheets? Let us zoom in. Many students can't identify this picture in their grand tests. But you need to be clear. Plasma cell matlab nucleus side par. Nucleus side par. Everywhere nucleus side par. You will keep looking around. You will say, yes ma'am, now I think I can identify. Nucleus is always chucked out. That is how I identify sheets of plasma cells. That is what I see on a bone marrow biopsy. But what do I see on a bone marrow aspirate? All these cells, beautiful cells. So remember, if you see some intracytoplasmic inclusions, if you see intracytoplasmic inclusions versus if you see intranuclear inclusions, they have different names. Intracytoplasmic, देखो cytoplasm में C वाला sound है, तो Russell bodies are in the cytoplasm. How did I say? Intracytoplasmic Russell bodies. And Dutcher body is gonna be in the nucleus. So if you see this in the cytoplasm, you know, अच्छा, cytoplasm मतलब Russell bodies. And if you see the inclusions in the nucleus, you know they are Dutcher bodies. But if you see nuclear and cytoplasmic, pura inclusion, ma'am, the entire cell is only looking like an inclusion, that is known as a mulberry or a Mott cell. Or you say that this time, ma'am, the cell is on fire, that is going to be flame cell. So what all do you see in multiple myeloma? Russell body, Dutcher body, mulberry cell, flame cell. Which is the most common antibody that I'm talking about that gets elevated? It is IgG, but please remember, flame cells are associated more commonly with IgA. How I have learnt it is, flame is आग लगाना, तो A antibody आग लगाएगा, ठीक है? A antibody आग लगा देगा. So IgA is gonna result in flame cells. Simple. Okay, now all said and done, ultimately the diagnosis of multiple myeloma has to be with M spike. So you can very well see, देखो blue वाला tracing, देखो blue वाला tracing is that of a normal person. Normal person में a first peak always goes for what? It goes for albumin. The second peak goes for alpha 1 proteins, alpha 2 proteins, beta proteins, gamma protein. You learn it with your hand. The first peak is always albumin, alpha 1, alpha 2, alpha 3 and gamma. So alpha 1, alpha 2, beta and gamma. I repeat, albumin, alpha 1, alpha 2, beta and gamma. But what did you see in multiple myeloma? The gamma region has undergone a spike because gamma region is for immunoglobulins, right? And that is what you see in a case of multiple myeloma. The gamma region shoots up. There is an M spike that is noted. Yes, multiple myeloma also done. And before I end this discussion of the WBCs, I think one machine is very important for us to know, which helps us diagnosing all the CD markers. The flow cytometry. This is how a flow cytometer machine looks like. Quickly tell me, what is the light that I use? We usually use a blue color laser which has a 488 nanometer wavelength. Question number 1. What are the colors? You can see lots of colors, red, blue, green, yellow, sab use ho sakta hai. They ask you the dye green wala. Remember the fluorescent dye? Fluorescent is fluorescent. FITC dye is the one which is going to be a green color. You don't have to learn the name of all. So you just have to know the light. The picture is only telling me blue color ka light hota hai, 488 nanometer wavelength. And the green color wala dye that I'm using is FITC. So what is the principle of flow cytometry? Tell me guys. The forward scatter of light is a measure of what? Forward scatter tells me whether the cell is chota or bada. So chota wala cell, less forward scatter. Bada wala cell, more forward scatter. Side scatter tells me how complex the cell is. It tells me about the complexity or the granularity of the cell. So this is going to show me how the rays are going to be side में scattered because it's a very, very complex cell. So simple. Size का छोटा सा cell, छोटा forward scatter. Big cell, big forward scatter. Granularity में less granularity, less side scatter, more granularity, more side scatter. So simple, forward scatter tells me size, side scatter tells me granularity. WBC chapter is over. We know what we are moving towards, the big cells, the mega cells. And what are these? These are the megakaryocytes. Megakaryocytes are what? Megakaryocytes are the platelet precursors. The only pictures that you get in megakaryocytes, guys, are gonna be the different variations. So पहले तो normal megakaryocyte देख लो. A normal megakaryocyte is basically gonna be a giant cell. It's gonna have lots and lots of nuclei. That is a normal megakaryocyte, because now have a look at this. If the megakaryocyte, suddenly look at the nuclei, man, they're becoming very chota, dwarf megakaryocyte. That is seen in CML. Again, this is a slide important only for INICET aspirants. Remember, chota sa dwarf megakaryocyte, CML sounds like small, so megakaryocyte becomes small. Where do you see staghorn megakaryocytes? Staghorn megakaryocytes are seen in SET. That is how we learn it. Staghorn is seen as essential thrombocythemia. Staghorn like the horns of a deer that you can see over here. Then if I see cloud-like megakaryocyte, cloud ki tarah ban gaya, that is going to be seen in a case of primary myelofibrosis. And finally, if you see these three metallic balls jaisa, pawn ball megakaryocyte, these three metallic balls, this is a symbol for which shop? These three metallic balls are a symbol that, you know, they take your gold and give you money. वो barter system वाला जो shop होता है, loan वाला shop, उसका symbol होता है three metallic balls. So the megakaryocyte is showing you three metallic balls, and that basically means that this is a pawn ball megakaryocyte that you see in MDS. So repeating, dwarf small CML, staghorn SET, essential thrombocythemia, cloud-like in primary myelofibrosis, and pawn ball is going to be seen in MDS. Your megakaryocytic story is just this much. The last part that we are left with are the blood bank images and the vacutainus. So a big sigh of relief, because the bulk of pathology images are coming to an end. Okay, so let's begin. Whenever you have to go towards blood banking photos, the first thing that you do is blood grouping. So they ask you what is going to be the analysis. Before I show you the analysis, you should know that anti-A, anti-B or anti-D ka color kya hai. If you remember, we had a mnemonic called BIG. That is how we had learnt it. There is a mnemonic called BIG which tells me that anti-A, anti-Sera is blue in color, anti-B is going to be yellow in color, and anti-D is going to be grey in color. Okay? So if I look at the blue color, this must be anti-A, then yellow color anti-B, and grey color anti-D. Then you'll say, I can also see something else, ma'am. What is this anti-human globulin? Anti-human globulin jo green color ka hai is used in the very famous Coombs test. In the blood bank, if you ever have to do Coombs test, you will do it with the help of anti-human globulin that is green in color. But wo kabhi use hoga. What I am talking about over here is the usual day-to-day usage, and that is going to be anti-A, B and D. That is A, B and D is big, blue, yellow and green. How do you do the diagnosis? This is how different images will be given to you. So ye dekho, the simple rule is wherever you see the clumping, jahan pe clump hai, wo blood group hai. Wherever you see the clump, wo blood group hai. Sabse pehle to the rule is that the control should be clear. Everywhere the control should be clear. Control means you've only added blood. There is no anti-A, anti-B, anti-D. Kuch nahi add kara, but wo totally clear hona chahiye. That is what you call as a valid test. If your control comes out to be clotted, pehle se hi clotted hai, then why will I add anything? Means the sample is kharab. This is an invalid test. Never ever read it. Repeat. Call for a repeat sample. First rule of the paper, control should be clean. Then see, कहाँ पे clump है? A में clump है, anti-A में clump है, तो मतलब जहाँ clump है वो blood group. Anti-A में clump है, blood group A. B में clump नहीं है, तो ये B blood group नहीं है. Anti-D में clump है. D is what? Positive, RH ना? तो this is a case of A positive. Let me make you practice more. Over here, I see a clump in anti-A, matlab A blood group hai. I see a clump in anti-B also, B blood group bhi hai. I see a clump in anti-D also, matlab positive hai. This is AB positive. Over here, I see a clump in anti-A, matlab A hai. And I see a clump in anti-D, A positive. Here I see there is a clump in anti-B, B, and in D, B positive. If only in B and nowhere else, मतलब B negative. If A and B में तो है, AB तो है, but D में नहीं है, This means AB negative. So simple. Where you see a clump, that is the blood group. Where you don't see a clump, that is not the blood group. Easy. Moving on to the next. What are the other methods? Guys, what is this that you use in a blood bank? This is the very famous ELISA plate. They ask you there are 12 wells in this direction, there are 8 wells in this direction. So the total number of wells are going to be 96. बस इतना पूछते हैं, total number of wells 12 and 8 के हिसाब से it is 96 wells. What else can you use for blood grouping? Gel card analysis. They've used anti-A, anti-B, anti-D and control. And I've already told you, when will you give something as positive? When you get a line on the top पे line आएगा तो positive, नीचे line आएगा तो it's gonna be negative. So can you now tell me guys, नीचे तो negative, any, top तो positive, PO. तो tell me, यहाँ पे top पे line है, यहाँ पे top पे line है, तो A and positive. This is an A positive blood group. नीचे मतलब negative. This is not B. This is A positive blood group. How easy to identify. Now let's look at the next instrument in the blood bank. This is where you go and donate blood. When you go and donate blood, your bag, your red color blood donation bag is kept over here. This is a biomixer. It basically helps in mixing your anticoagulant along with the blood. Whatever anticoagulant you have added along with the blood, it will help in proper mixing. What are the different blood bags that you have in the blood bank department? Look at this. First, you will always find the needle. Needle jahan jayega, that will become the mother bag. So the needle is going here, that becomes the mother bag. This is where there are two types of bags. Either 350 ml of blood will be collected or 450 ml of blood will be collected. That is your whole blood. You will divide that whole blood into red blood cells, into platelet-rich plasma and fresh frozen plasma. You will divide that into red blood cells, platelet and plasma. So these three then become your component bags. That is why they say that one donation can save 3 lives. You can spread one blood into 3 parts: red blood cell, platelet, plasma. Right? So do you know, I call this TAT bag, top and top. Why? Sari tubings top pe hai. When sari tubings top, bottom pe koi bhi tube nahi hai. When all the tubings are on the top, I call it top and top bag. Whereas look at the next one. Over here, this was the needle. Okay, ma'am, this is the needle, and you said needle will go into the mother bag. This is the mother bag. But over here, tubings are at the top also, tubings are at the bottom also. So this becomes a tab bag, top and bottom. So simple, look at the mother. If mother has tube upar, all upar, that is top and top. If mother bag has tube upar, niche, that becomes top and bottom. Please note, there is one pouch extra over here. What is this pouch known as? Chota sa pouch alag se bhi hai. This alag se pouch is known as a pre-DB, pre-donation bag. Pre-donation bag means that first 30 ml of blood. First 30 ml of blood will go into this because first 30 ml has your antiseptic, skin, little contaminants. So basically all the contaminated blood will go into this, the first 30 ml. And then after that what you will get will be pure blood. Then your mother bag will have all pure blood. So little blood can go on the side in the beginning, 30 ml. That is known as PDB. Next image came in your AIIMS exam paper. See the same picture. You have a needle. What is this? Let's label. You say, ma'am, ye wala jo hoga, this is needle. Then this chota wala pouch must be the pre-donation bag. Then finally, this is the mother bag. And the rest must be the different component bags. Yaha jayega RBC. Over here, you're going to have RBC. Here, you're going to have platelets. And here, you're going to have plasma, right? So now you say there's one extra thing that I can see over here, and that is a filter. I have a problem with WBC. I always say WBC ko nikalo. Remove the filter. Remove the WBC. Filter them out. Why? Because firstly, WBCs will carry the risk of cytomegalovirus transmission. If someone has cytomegalovirus, that will get transmitted by WBC. Second, WBC releases a lot of cytokines, and cytokines result in a very important transfusion reaction. Which transfusion reaction? Febrile non-hemolytic transfusion reaction. That happens because of cytokines. You've read this in medicine. Patient febrile, patient has fever. Non-hemolytic transfusion reaction is because of cytokines. So you say, ma'am, I don't want my patient to have fever and I don't want my patient to have CMV. So agar CMV or cytokines nahi chahiye, remove the WBC. How do I remove the WBC? By adding a filter. This will remove all the WBC. So now the RBCs that I have, do they have any WBCs? Nahi. Pure RBC hai, no WBC. WBC has been reduced from the RBC, leuko-reduced RBC. So they ask you, if you want to eliminate the risk of febrile non-hemolytic transfusion reaction, which kind of blood product will you give? I will give leuko-reduced RBCs. Moving on to another AIMS exam question. What is the Penta blood bag? Penta blood bag, सबसे पहले तो learn PE for Penta, and PE is going to be for pediatric blood transfusion. When you have to give a chota bacha blood, come on guys, you can't give 450 ml of blood to a newborn baby. You will say, ma'am, I will make chota pouches out of it. Maybe 100 ml I will divide into 4 pouches, and then I will give 1 pouch as and when required. I can't give 450 ml in one go. The child will die of overload only then. Na? So pediatric ke liye I will make chota. Like you have your mothers tend to do this. Whenever in your grocery you get something big, your mother divides it into chota containers. Same way. When we've got so much of blood, and to my kid I can't give so much of blood, I divide it into chota pouches and keep it in my blood bag. That kind of a bag is known as a Penta bag. So PE for Penta, PE for pediatric blood transfusion. Done with the bags. Quickly, do you want to revise all the shelf lives and the anticoagulants? Jaldi se. So tell me, if you have used the anticoagulant as ACD, what is it? How did we learn it? ACD and CPD. They have 3 alphabets. So the shelf life of blood is going to be 3 weeks. Matlab 21 days, 21 days. I'm talking about the shelf life of the red blood cells. Shelf life of the red blood cells. So simple, 3 alphabet wala anticoagulant use kara, तो 3 weeks का shelf life. CPD-A. If I add adenine मतलब ATP add कर दिया, ज़्यादा live करेगा cell ना. CPD-A. How many things? 5 alphabets, 5 weeks, 35 days. And finally, if I have SAGM का दूसरा नाम है CP SAGM. Count with me, CPSAGM. 6 alphabets. This means the shelf life is going to be 6 weeks. That is 42 days. So please note, ACD, CPD, 3 letters, 3 weeks. CPD-A, 5 characters, 5 weeks. CP SAGM, 6 characters, 6 weeks. Of course, which is the best? Which will store the blood for maximum best, but very expensive. We can't use it. The most commonly used is CPD-A. Economical bhi hai and 5 weeks bhi hai, to theek hai na. CP SAGM is the best undoubtedly because it can keep your blood for 6 weeks, but it's damn expensive, not practical to use it on a day-to-day basis. And now once you've done the anticoagulants and the shelf life, why don't you do the temperature? Anything to do with red blood cell refrigerator में रखा जाएगा. Refrigerator means you are going to put it in a 2 to 6 degree centigrade for how much time? अब how much time तो depends ना. Which kind of anticoagulant have you used उस पे depend करेगा. ACD, CPD, CPDA, CP SAGM, 3 weeks, 5 weeks, 6 weeks, that will depend. Platelet rich plasma is kept at a 20 to 24 degree for 5 days, but there's a condition. And that condition is that you have to continuously move the platelet, otherwise the platelet will clot, and this is the machine. This is a platelet agitator. What did I say? You keep the platelet rich plasma at 20 to 24 degrees centigrade for 5 days on continuous agitation. You continuously have to move it, right? That is a platelet agitator. This keeps moving as a left, right, left, right. Coming back, when I'm talking about anything to do with platelet, random donor platelet, single donor platelet, any platelet thing, rules are the same. 5 days, 20 to 24 degrees, constant moving. Now anything that is frozen, either a fresh frozen plasma or a cryoprecipitate, it is kept at minus temperatures because frozen hai, and anything that is frozen can be kept for 1 year. Tell me guys, fresh frozen plasma mein kya hai? Ma'am, all clotting factors are there. 5 and 8 thoda kam hota hai. 5 and 8 are missing. Rest all of them are there. What is cryoprecipitate? It has factor 8. Factor 8 ka carrier kaun hai? Von Willebrand factor, so that is also there. It has the first factor and it has the last factor. Last factor is 13. That is what is cryoprecipitate. Repeating, it has 8 and VWF ka carrier. They are always together. They are in a relationship. The first factor and the last factor, that is what is present in cryoprecipitate. Fresh frozen plasma has all the factors but doesn't have 5 and 8. 5 and 8 are less in amount. Done with these. Now we can move on to the last part of blood banking, and that is the famous apheresis machine. You know what is an apheresis machine? That whatever component you want to keep, like you say that ma'am, I want to do platelet. Example, you want to keep only platelets because there is a dengue season going on. You want only platelet. तो इस donor से platelet रखा, बाकी सब वापस कर दिया. You kept the platelets and you returned the red blood cells and the plasma to him. You said, why should I take all your blood when I only need platelets? I will only take platelets from you. So that machine, this looks like one of those NASA ka space rocket wala machines. This NASA type of machine is apheresis machine. ठीक है, तो apheresis machine, and it can be for anything. You only want to keep red blood cells, keep that, return everything else. You only want to keep platelet, keep that, return everyone else. So whatever you want to keep, that one product you keep and you return everything else. That is an apheresis machine. The last part of hematology that we have is, of course, the vacuotenus. Let's get going. I hope you're finally taking a sigh of relief because it comes to an end, right? Okay, so what are the vacuotenus that you have to know out here? The first one is the story of all the EDTA vacuotenus. Guys, which form of EDTA do we use? We use K2 EDTA, and you will say so many colors just for EDTA. Yes, first listen to a story. There's a white girl, a pearly white girl, and every white girl is always very fond of getting a tan. She'll say, I want a suntan. So there is repeating. There is a white girl who wants a suntan, and she's so white, she belongs to the royal family. She belongs to the royal family, and every girl's favorite color is pink and purple. So ho gaya, white girl who wants a tan, belonging to the royal family, favorite colors are pink and purple. These are the EDTA vacuotenus. When do you do what? Remember, pearly white, P for P. Whenever you want to do PCR testing, pearly white. Royal family people are rare na. So rare elements agar dekhna hai, copper, zinc, so you will do royal blue. Pink, girls का favorite color. Pink is sensitive color. Girls are sensitive. Pink is sensitive. So blood bank हमेशा sensitive part होता है of your hospital. So for blood bank samples you use pink. Tan, you will learn tan, tin, lead. Tan, tin will remind you of lead. So this is going to be used in lead poisoning cases. If you have a lead poisoning patient, you will collect his sample in this vacuotenus. And finally, the purple or the lavender, the bread and butter of a pathologist. सब कुछ इसमें होता है. Complete blood count, peripheral smear, reticulocyte count, ESR by Wintrobe, everything is done in it. Like I said, it's the bread and butter of a pathologist. These are all the EDTA vacuotenus. Sorted? The next one are going to be the heparin. Remember, heparin is hara. Heparin is hara. So I can see two hara shades over here. I can see one light green and I can see one dark green. So light green matlab lithium heparin. Li for light, Li for lithium heparin. Dark green, DANA, that is sodium heparin. Ho gaya easy? Light green, lithium heparin. Dark green, sodium heparin. DANA, Li. Same. What are they used for? Whenever you have to do arterial blood gas analysis, you use the hara vacuotenus, the heparin vacuotenus. So remember, light hara, lithium heparin, dark hara, sodium heparin. Simple. Moving on to the next one, G for G. Whenever you have the gray vacuotenus, what are you going to use it for? All the glucose estimations. Glucose estimation is done. So what are the two things? Firstly, it has potassium oxalate. Potassium oxalate is the anticoagulant. It will not let the blood clot. Whereas sodium fluoride is going to be the additive. Sodium fluoride inhibits an enzyme. That enzyme is known as enolase. As a result of which, the glucose utilization, no one will be allowed to use glucose because I will not let anyone use glucose. Now I have to measure glucose. If my RBCs use up glucose, then what will I measure? So you will have to stop the glucose utilization. You will have to stop glycolysis. You stop it by stopping enolase. Who stops enolase? Fluoride stops enolase. So read the question carefully. In the gray vacuotenus, have they asked me for anticoagulant, that is potassium oxalate? Have they asked me for additive, that is sodium fluoride? Coming to the next one, the light blue vacuotenus, which is everything 333. 3.2% of trisodium citrate is going to be used, and once you take the blood, you are going to invert the test tube 3 times. So 3.2% trisodium citrate 3 times is what you're going to invert the tube. What do you use it for? You use it for all your coagulation studies. Coagulation studies matlab PT, APTT wala studies. And you can also use it for ESR. ESR by which method? By the Westergren method. Okay? Next, there's one more tube. There's a black color tube. That black color tube also has the same, guys. It has the same trisodium citrate. You'll say, "Arey ma'am, blue wale mein bhi trisodium citrate tha, black wale mein bhi trisodium citrate hai. Blue wala also you were using for ESR estimation by Westergren. Black wala also you are using for ESR estimation but by automated." Bas wahi difference hai. One is by a human being, one is being done by a machine. So now, if I ask you for ESR estimation, number one, you had the Wintrobe tube, जो human being करेगा. Next, you had the Westergren pipette, जो human being करेगा. And next, you have the machine that is automated. So please note, when you're talking about Wintrobe से करना है तो EDTA में collect करो. Wintrobe से करना है तो EDTA. Wintrobe ends with the EDTA. Westergren and automated, both of them, you're going to use the same trisodium citrate, but the colors are different. For Westergren, you are going to use the light blue Vacutainer, and automation. Automation is said to be the black day for humans because soon we will lose our control and everything will become automated. So automation karna hai to black Vacutainer use karo. Simple. ED done. So till now I was like emphasizing, don't let the blood clot. Now I'm saying, please let the blood clot. Because if the blood will clot, only then will I get the serum. So when do I need serum? I need serum whenever I am interested in doing some, say, enzyme studies, or I want to study for some hormones, thyroid profile, prolactin, FSH, LH, all this, kidney function test, liver function test. I need serum for it. So these are gonna be the red and the yellow which will let the blood clot. Why? Because the red also has a clot activator, and the yellow one also has a clot activator. But the difference is that red mein the clot will take place in 60 minutes, whereas yellow wale mein the clot will take place in 30 minutes. Why so? Why yellow is very fast? Because along with it, it has a gel. It has an additional gel inside it which will make the blood clot very fast. So remember, red ke andar 60 minutes mein clotting, yellow ke andar it is going to be gel ke saath jaldi 30 minutes mein clotting. But you are like one of those super intern who's in hurry. You say, ma'am, itna time nahi hai. I don't have time. So 60 minutes bhi nahi hai, 30 minutes bhi nahi hai. I have 5 minutes. Please blood ko 5 minutes mein clot kar do. I say, okay. Then I will use the orange Vacutainer, because orange mein, if I count the alphabets in orange, it has roughly 6 alphabets. So I will need approximately 5 to 6 minutes for clotting. It has a very important gel, thrombin gel, that can clot the blood in 6 minutes also. And how many times will you invert the tube? 6 times invert karke laoge. So if you're in too much of hurry and say, ma'am, HOD is coming on rounds, jaldi hame reports de do. So I'll say arrange for an orange Vacutainer, which you hardly get in the lab. So orange Vacutainer, 6 alphabets, 6 minutes mein blood will clot, 6 times you will invert the tube and get it to me. Sorted. The last image that we have in hematology and pathology is going to be the improved Newbur's chamber. The only thing that I wanted to revise with you was that where are you going to count WBC, RBC and platelet? So I've got you a bigger version. The WBCs will be counted where? The WBCs are counted in the 4 peripheral squares. The big 4 peripheral squares are going to be for your WBCs. Pura square count karoge. Where will you count your RBCs? Look at this. Center mein, but center may be corner, center. You don't count it in the full square. You count it in the 4 corners and the center. That is RBC. And where do you count the platelets? I'll take the platelets with the chota sa yellow color. So platelets are counted everywhere. Platelet in the center box, platelets are counted everywhere except 2 lines. 2 lines chhod dena, 2 lines pe count karna, 2 lines pe chhod dena. So remember, this is how platelets are counted. They are counted everywhere, but you will leave 2 lines. These 2 lines you do not count, you don't count here. Other 2 lines you will count. Okay? So repeating, the WBC is going to be at the 4 peripheral squares. RBC is here, and center. The 4 corners and center, and platelet is everywhere. Count 2 sides, don't count the other 2 sides. But how are you doing this counting? Aren't you using some pipettes? Yes, there is an RBC pipette and a WBC pipette. How do I identify? RBC mein sab kuch red hoga. There is going to be a red color bead and there is going to be a red color mouthpiece. So remember, red bead, red mouthpiece, RBC pipette. If you have a white bead and a white mouthpiece, this means it is a white blood cell pipette. Sab kuch red hai to RBC pipette, white hai to white blood cell pipette. You say, ma'am, exam mein black and white photo aaya tha. Red, white pata nahi laga. Then you will pick up the labelings. If you see a labeling of 0.5, 1 and 11, it is a WBC. Why? Why the dilution being kept less? Because WBC is in thousands. RBC का देखो 0.5, 1, 101. Why is there such a big dilution? Because RBC is in millions. So simple. If you get a 0.5, 101, that is RBC pipette. If you get a 0.5, 1 and 11, that is a WBC pipette. So what are you diluting it with? RBCs are diluted with the DESI and the Haim fluid. This is only important for INI-CET. DESI and the Haim fluid. WBC is going to be by the Turk fluid. And platelet is going to be by the Rees and Ecker fluid. And there's a very simple way of learning it. The way you write platelet, you will make an R out of it. So Rees and Ecker fluid ho gaya. DESI wala doctor, so that is going to be RBC. And Turkish people, white people, so Turk fluid for white blood cell. Okay? Turkish white blood cell. Rees and P look the same, so platelet ke liye Rees and Ecker. And DESI is for RBC, that is going to be the doctor. And with that, we have wrapped up our entire section of not only hematology, but thankfully so, we have finished the snapshot of entire pathology portion. I hope you found it useful. Guys, this is something you should never be bored of, because you number of times, just put it on 2x speed every time you have time. And I think if it's for example, a 6-hour course, on a 2x speed, it becomes a 3-hour syllabus. And whenever you don't feel like study, you just listen to these videos. Trust me, a lot of your pathology gets covered. I hope you found it beneficial. Thank you.